Sarosh, you will make the opening remarks?
Sorry?
Yes. So waiting to go live. Sir.
I think that should be good enough, Satish.
No, he said he'll give a green signal.
Okay, fine.
So Chetil, are we done?
Yes, sir. Chetil, can we go live?
Yeah, yes, sir. We are in live.
Yeah.
Good to go, sir.
Good. So good morning, everyone, to this edition of the Continuum. Professor Katra.
Sir, please start.
Okay, start again. Yeah, are you done? Yeah. Okay, so good morning, everyone, to this edition of the Continuum. Professor Katra, who started the Continuums and made them grow in India, is here. Dr. M.A. Khan, who's taking part now in the Continuums regularly, is here. Dr. Ashok Shirsat is here. And today we have a special guest, Professor B.S. Singhal. Today's topic is multiple sclerosis. And as we all know, Dr. Singhal has a long-term interest in multiple sclerosis. He's published a lot, and his knowledge stock on the demyelinating diseases is very large. So welcome, sir.
Thank you.
And I think with that brief introduction to today's Continuum, let's begin with the first speaker, that is Abhijit from JJ, guided by Dr. Azad. Also to mention, we've got Dr. Rajesh Benny today, who's coming to Continuum as a mentor. So Abhijit will present diagnosis, differential diagnosis, and misdiagnosis of multiple sclerosis. And he's been guided by Azad. Abhijit, do go ahead.
Sir, okay. Good morning, all of you. Multiple sclerosis is a chronic disease that is characterized by the inflammation and the demyelination of the central nervous system. It is associated with the axonal neuronal damage and self-reactive immune cells, such as the microglial lymphocytes, that will gain access to the myelin sheath and cause the damage to the myelin sheath. And it is characterized by the MS lesion that is called as the MS plaques. The multiple sclerosis present with the multiple symptoms that include the sensory symptoms, motor symptoms, can be a visual problem or can be a bladder problems. The multiple sclerosis is a complex disease, so its clinical and the radiological heterogeneity make it diagnostic very challenging. So it required the timely change diagnostic approaches since 1965. The Schumacher was the first to propose the diagnosis for the multiple sclerosis in 1965. That was actually he proposed for his ACTS trials for the patient with the relapses. Later, it was modified in 1960 by the Poser, when he included the clinical and the paraclinical criteria. Later on, the MRI criteria were also included for the diagnosis of the MS in 1980s. The first McDonald criteria was published in 2001, and that was revised timely in 2005, then 2010, and recently it was revised in 2017. What are the purpose for the revision of the criteria was to make the diagnosis of the MS as early as possible, so that treatment can be started and patient can have the better life. The diagnostic criteria of Schumacher was based on the 4 pillars. First was the syndromes; those were typical for the MS-related demyelination. Second pillar was the objective evidence of the central nervous system that we are dealing with. And the demonstration, third pillar was the demonstration of destination, time and space. And fourth pillar was there should be no better explanation for the symptoms under evaluation other than multiple sclerosis. So which are the typical symptoms that comes under the typical symptomatology of the multiple sclerosis? First is the optic neuritis, brainstem syndromes, trigeminal neuralgia, cerebellar syndromes, and the transverse myelitis. So it is very important to have the symptomatic approaches, and we should be able to differentiate between which are the typical symptoms that will point out toward the MS or the CIS, or which are the atypical symptoms that will point to the other entities than multiple sclerosis. The patient with the optic neuritis, the typical optic neuritis presentation will be at a younger age, less than 45 years. Onset with the acute, subacute onset, and the progress that will be progression. There will be progression over the few days or the week. Symptoms more oftenly present unilateral, and there will be a subnormal vision loss. On examination, we can have normal or swollen optic disc, mild periphlebitis. There will be spontaneous vision improvement is also expected in 2 to 3 weeks, and those lesions are more often steroid responsive without any steroid dependence. But on the other side, atypical optic neuritis, the patient will be more often elderly. Onset will be acute, subacute, or sometimes the progression can be more than 2 weeks. Symptoms can be unilateral, but that will be severe symptoms can be a bilateral, or there can be a rapidly sequential both eye involvement and the chiasmal lesions. On the examination, we can get marked swollen optic disc, hemorrhages, marked periphlebitis, and there will be lack of recovery within the 5 weeks. Again, these are the more often steroid unresponsive, and if response to the steroid occurs, these lesions relapse after the steroid withdrawal. Now, the typical brainstem syndrome will be presented in acute onset, subacute progression, can be associated with the intranuclear ophthalmoplegia. There may be associated with multifocal clinical presentations, and there will be no symptomatic manifestations. On the other side, the atypical presentation will be more in the elderly persons with onset with the hyperacute. That will again suggest there can be vascular etiology. The signs will be along the vascular territory. Patient presence of isolated trigeminal neuralgia. Patient can have fluctuating oculoverbal weakness that can again point toward some NM junction pathology. No remission, or can be associated with the fever or the meningism. That will suggest there might be a meningitis. The typical myelitis will be acute, subacute, that will progress over few days or week. There will be more often partial myelitis, pure sensory rather than motor, presence of Lermit sign, and the MRI that will suggest 1 to 2 short segment involvement with spontaneous remissions. Atypical myelitis will be having the hyperacute onset or the insidious progression. There will be more often complete myelitis rather than partial myelitis. There will be sharp sensory levels, presence of radicular pain, areflexia, and the holocord involvement or the cord segment more than 3 segment involvement, and no remissions are the characteristics for atypical myelitis. When the patient present with the symptom, there should be the objective evidence of the CNS lesion corresponding to the symptoms. This objective clinical evidence can be a clinical or can be a paraclinical. If the patient present with the optic neuritis, the presence of relative afferent papillary defect can be considered as the clinical objective evidence. Patient with brainstem syndrome, internuclear ophthalmoplegia can be considered as the clinical objective evidence of the symptoms. Which are the paraclinical that proposed by the Poser in 1983. Those include evok potential, can be sensory or the visual evok potentials, CSF analysis, and the MRI. As we know that in the multiple sclerosis, there is not only the T cell involvement, there is beta cells involvement also there, so that there will be the increased intrathecal IgG synthesis. So that was considered in 2001 revision of McDonald criteria, where the weightage was given to the elevated IgG index, and IgG index more than 0.7 was considered to be the more possibility toward the diagnosis of the MS. And later on, the 2017 criteria, the CSF restricted more than 2 oligoclonal bands were considered for the substitution of the demonstration in time also. Again, the CSF also very important for the not only diagnosis but also for the differentiation, because typically the multiple sclerosis patients CSF protein will be less than 100 and cells will be less than 50. If there is pleocytosis, then we should think about the other infectious or the other inflammatory etiologies. The MRI being the very revolutionary for the diagnostic for the multiple sclerosis, it has been evolved. Many criteria were set up since 1988. First was set up the PATI, and latest in 2016, the Magnimus criteria was proposed. That is magnetic resonance imaging in the multiple sclerosis. They define the dissemination in time and the dissemination in space. For the criteria to fulfill the dissemination in space, there should be at least 2 of the 5 following areas involved. That includes the periventricular. There should be more than 3 periventricular lesions. minimum criteria for the periventricular lesions are kept as 3 because periventricular lesions are very common in other etiology also, such as vascular or any migraine etiology. More than one lesions in the juxtacortical area, more than one lesion in the infratentorial lesion, more than one lesion in spinal cord, and here more than one lesion of optic nerve was also included in 2016 Magnimus. That is not included in 2017 Magnimus criteria. Again, for the fulfillment of the dissemination in time, either of the two should be there. A new lesion that appeared over the as compared to the previous scan, irrespective of timing, that can be a due to bright spot lesion or the gallium enhancing lesion, or the presence of the enhancing and the non-enhancing lesions on the same scan can be considered as a dissemination in time. So in 2017, we know that the criteria for the MS was revised as 2000 McDonald criteria. Again, the same principle is there, that we should fulfill the criteria for the dissemination space and dissemination time. Again, the two major revisions were there. Even in the PPMS criteria also, they have included the spinal cord lesions, 2 or more T2 hyperintense spinal cord lesion for the diagnosis of the primary progressive multiple sclerosis. The two major revisions in the McDonald criteria was CSF specific oligoclonal bands were considered for the substitution of DIT. That was not in the previously revised criteria. Again, the cortical lesions were also included for the fulfillment of the dissemination of space, because MS is not only the white matter disease, it also involves the gray matter. So we'll just understand what is mean by the dissemination is space. Dissemination space means there should be at least two anatomical distinct locations for the lesions. Now, the dissemination space required at least 1 to 2 hyperintense lesion that should be more than 3 mm along the long axis, can be symptomatic, non-symptomatic, and should be present in the two of the four area. Here the areas are the same as we have previously mentioned in the Magnimus, only the optic nerve is not involved here. And the dissemination in time, as we know that MS is not a monophasic disease. So the new CNS lesions over the time that suggests there is some ongoing disease or there is subclinical lesion. So the dissemination time criteria, again the same as that Magnimus, there can be either of any new lesion on the follow-up scan or the presence of the enhancing or non-enhancing lesion on the same scan. Again, in 2017 criteria, as I previously mentioned, CSF oligoclonal bands are considered for the substitution for the DIT. Here, some example of the dissemination in time. Here we can see the one T2 hyperintense lesion is seen in central ovale. That is also enhancing on the post contrast. Here are the two hyperintense lesion in the subcortical region, where only one of that is enhancing. Again, this is the black hollows on the T180 image. That again suggests that there is ongoing disease, CNS lesion, and that is again the predictive for the patient with the CIS that can land up in the clinically definite MS, or these are also found to be correlated with the disabilities in the multiple sclerosis. Now, these are just to summarize the MS findings in the MRI. These are some periventricular lesions. Those are the oval shape, more than 3 mm, perpendicular. Some lesions are perpendicular to the periventricle. That suggests there is the evidence of the perivenous inflammation. This is called the Dawson's finger. Again, the one subcortical lesion that is just abutting the cortex, and there should be no any intervening white matter. Okay, and this lesion is cholezoseptal involvement. Here, the short segment spinal lesion. Those are the specifically peripheral place, and that occupies only less than 50% of the cord area. These are the optic nerve enhancement lesion. Again, these are the short segment enhancement. Okay, the lesions are more often placed anteriorly without the chiasmal involvement. The next criteria, there should be no better explanation for the symptoms under evaluations. So for that, we should pay attention toward the red flags and the atypical symptoms. We already covered the atypical symptoms. Now we'll just see the red flags. In the continuum also, they have given almost 4 pages of the red flags. I'll just try to summarize some symptoms. If the patient is having the predominant pulmonary symptoms, then we should think about the sarcoidosis, lymphomatoid granulomatosis. If the patient come with the multiple cranial nerve involvement, then we should think about the sarcoidosis, tuberculosis, Lyme. If the peripheral neuropathy is a presentation of the patient, we should go for chasing vitamin B12 deficiency, adrenoleukodystrophy, metachromic leukodystrophy. If on MRI we get multiple microbleeds or hemorrhages, then amyloid angiopathy, myositis, CADASIL or vascular tissue should be on our card. If the patient is having a hypothalamic dysfunction, then the sarcoidosis, anemohistiocytosis should be on our card. A patient present with the extrapyramidal symptoms, then Whipple's, Wilson's, we should think about those entities. And again, the other red flags are if the patient present with the recurrent abortion, if there is pre-existing connective tissue disease, strong positive family history, meningeal involvement, simultaneous enhancement of all lesions or the symmetrical lesions, which are bit quite odd for the multiple sclerosis, presence of episodic of headache that can point toward the migraine or early dementia. These are the red flags. Now coming to the DDs, which are the differential diagnosis, there is a long list for the DDs. I cannot go through all those things. We'll just see some of the most common encountered disease. So small vessel disease is extremely common condition that is present in elderly groups with having some vascular risk factors as hypertension, diabetes. The white matter enhancement in small vessel disease can be confused with the multiple sclerosis, but you should keep in mind this enhancement will be along the vascular end zones. So that will mostly include the basal nuclei, coronal radiata, and the centrum summae. If the lesion is placed in the brainstem, that will occupy the central part of the brainstem because of the centripetal pattern of the feeding vasculature. This is the chart to just to differentiate between the white matter apparent lesions in the vascular and the multiple sclerosis. In the multiple sclerosis, the corpus callosum and the eufibrin environment is common as compared to the vascular. In the vascular, there will be the more cortical lesions, basal ganglion involvement. Again, the hyperintensity in the vascular region will be more in the frontal in the parietal regions as compared to the multiple sclerosis. The hyperintensity will be placed more often in the anterior temporal lobe. Again, the colorectal interference involvement is very typical for the MS because the involvement of small penetrating vessels near it, but it is less likely in SVD or the small vessel disease because colorectal is very rich, vascularly rich because of the presence of collaterals. Here again, the centrally placed lesion in the brainstem in the vascular lesion as compared to the multiple sclerosis where the regions are typically placed peripherally. Here, the lesion is placed near the fourth ventricle. One is near the interior of the trigeminal nerve. Now, this is the juxtacortical lesions that is just abutting the cortex, and that is more than 3 mm without any intervening white matter. Here, in the vascular lesion, this lesion will be quite little far away from the juxtacortex, and there will be the presence of the intervening white matter. Now coming to the one differential, that is tumefactive demyelination. It can be easily confused with some SOL or the glioma, but the main differential will be there will be the open ring enhancement on the post contrast, and the patient and this lesion on perfusion will be having the low cerebral blood flow and the high ADC values. Again, coming to other DDs, the ADAM that common in children's that follow the monophasic course, and it occurs after the infection vaccinations. When MRI DD will be the lesions will be diffuse, more often symmetric, and that will involve the basal ganglion. As we think here, the thalamus and the basal ganglion involvement is there. Again, other DDs we can see for the demyelination is NMO spectrum disorders, where the lesion will be the more oftenly involving the optic nerve, and a patient can present with the myelitis, optic nerve involvement with the longitudinal optic nerve involvement, and that will occupy more than half of the length with the chiasmal enhancement. Again, the myelitis lesion will be centrally placed, longitudinal, more than 3 segment involvement, and that will be centrally placed as compared to the MS lesions, which are more oftenly peripherally placed. Again, on the brain MRI, we have the peripendymal surface involvement because acroporin 4 channels are peripendymal locations. MOG is again the other entities whether patient can present with optic neuritis, myelitis, or the Adam-like encephalitis seizures. Again, in the myelitis, we can have the extensive optic nerve involvement. In 20% of the patient, there can be a bilateral involvement, and the optic nerve will be the more edematous, okay, tortuous, and there will be the optic nerve head enlargement also, with predominant perineural optic nerve sheath enhancement. Again, the myelitis, there can be a short or longitudinal extensive myelitis in the MOC, associated with the cord swelling, and that will more often associated with the conus of the spinal cord. Again, the other DDs are the neurobechests, neurosarcoidosis, Sjogren's. So we cannot go details. Just a recommendation for the prevention of the multiple sclerosis and the misdiagnosis. We should pay attention to typical demyelinating syndrome. Those are typical for the multiple sclerosis. And we should remember the McDonald criteria is only for the typical presentation, not for the atypical presentation. Use of the prior symptoms for the fulfillment of the dissemination in time criteria, you should be very cautious, very cautious, because we should not take the non-specific signs such as the hyperreflexia or increased tone. Rather than, we should pay attention to clinical specific signs such as presence of the RAPD or presence of the internuclear ophthalmic lesion. MRI lesions and their characteristics, we should be aware of the all characteristics of the MRI lesions in the multiple sclerosis. And the CSF evaluation is mostly the mandatory for the not only for the diagnosis but also for the differentiation of the multiple sclerosis. Just to summarize, be cautious with the atypical presentations. McDonald criteria is for diagnosis, not for the differentiation. Differentiation should come from the clinician based on the patient's history and the clinical examination. The preclinical state of the disease is still unaddressed in McDonald criteria, and we hope for the revision for the same in the future. Thank you.
Thank you. Thank you very much, Abhijit. I think, yeah, you stopped sharing. So let's first ask Dr. Azad for his comments, and then we open it for a brief discussion. Azad, you want to make any comments?
Yeah. Good morning, everyone. Yes, Abhijit has presented most of the things. Just a couple of points. So like Abhijit said, the diagnosis doesn't happen by trying to fit the patient into McDonald's criteria. No, the diagnosis first happens by ruling out any other cause. Then if we think, yes, this is probably MS, before starting the disease modifying therapy, etc., then we may want to be sure by putting it in the McDonald's criteria. So McDonald's criteria is not number one. It should probably be number 2 or 3. And like is discussed in most of the multiple sclerosis meetings, there is obviously a heated search going on for any biomarkers. No biomarkers are yet very successful. The oligoclonal bands which were added obviously are the closest, but again, we have to follow many rules before diagnosing an oligoclonal band as sensitive and specific for MS. Number 1, it should be done in the correct method. Number 2, they should obviously outnumber the CSF oligoclonal bands. Number 3, there should be no clinical signs suggestive of meningitis or neuroinfection, which can also give us isolated CSF bands. And number 4, obviously, the sensitivity of oligoclonal bands increases by the outnumbering to CSF. So if it is 1 to 3, it's called predictive of MS. 4 to 10 is very predictive of MS. And if there are more than 10 oligoclonal bands, then yes, it is highly predictive. So OCBs were the only ones. Apart from that, neurofilament light chain, they say it helps in maybe diagnosis, not really, because it's very non-specific, but it may help in seeing it for treatment efficacy. Studies have been done on using fingolimod and natalizumab, where the NFL levels came to normal after therapy. Apart from that, no real biomarker has hit the dot yet. So that search continues. And so there's a long way to go, I think.
Thanks, Azad. I think if I can float one question to all the senior people. What is the most common differential diagnosis that we have seen, which in our setting, which really looks like MS and mistakes have been made, that we have to really be aware of? Would Dr. Singhal want to make a comment on that?
No, I think Abhijit really, and Azad also clarified it. I think the most common thing, of course, are the non-specific white matter lesions, which can be seen with migraine, that can be seen with diabetes, hypertension, aging. That, in fact, is the commonest thing which has been mistakenly called by the radiologist, perhaps no more now, earlier in our days, as the multiple sclerosis or demyelinating lesions. They always write down query demyelination, query ischemic.
Correct.
The age consideration, which Abhijit emphasized, is also very important.
Any other comments? Dr. Katrak, sir, you want to make any comments? Dr. Khan, Dr. Shir, sir.
I think what is the comment that I'd like to make is that I think the small vessel disease is radiologically one of the most common white matter hyperintense lesions that we see in day-to-day practice. Whether that translates clinically into a mimic of MS is entirely a different question.
Correct.
Clinically, the closest differential diagnosis will be NMO spectrum disorders. But
Yes.
there are many differentiating features between MS and NMO spectrum disorders.
Yeah.
I think people are getting more and more aware of NMO spectrum disorders. It is coming much more into the differential diagnosis of MS. The other comment that I would like to make is about neurofilament light. And I think it should be considered something like the CRP for MS. The reactive protein for the neurologist is neurofilament light. It comes into strokes, it comes into dementia, it comes into MS, it comes into so many other different aspects of neurology. And I think it is an evolving field. The last word has not yet been said about neurofilament light, you know.
Yeah.
Sarosh, that is actually
I think more
for, as Azad had said, is more to assess the, how the drugs are being effective or not, and also for the progression of the disease. Someday
So
we'll
in tumefactive demyelination, we have between primary CNS lymphoma, glioma, and tumefactive demyelination. Okay, we have those three different data for tumefactive. Would Asad like to make any comments?
Only in the pediatric age group, I think one has to be with cautious. It can be more.
Can I request people to mute them? Mute their mic. Yeah. Fully, your mic needs to be muted. Yeah. I think just for the benefit of the younger people here, a midline cut is a good cut to differentiate vascular related images from demyelination related images, because demyelination affects the corpus callosum. So the midline cut is much more likely to be abnormal in MS, vis-a-vis the vascular ones will be on the sides. Ashok, you want to make a comment? Maybe that comment we take and then we go ahead.
About misdiagnosis is that if you see the functional neurology literature, the commonest reason where non-MS are treated with MS treatment is misdiagnosis of MS. Overdiagnosis, white matter changes is still the biggest crime that neurologists commit in the management of non-MS patients with MS treatment. That is the data from the functional neurology literature.
Only
That's
one
good to
more
know.
comment which I'd like to
Yes,
make
sir.
for the postgraduate students.
Yes.
That bilateral optic neuritis is more common in children with MS, whereas in adults it is a unilateral optic neuritis. Bilateral optic neuritis in adults is a rarity.
More with
But in
NMO
children,
and
it is more common in children. This is
and
for
in
the
adults
postgraduate.
more common with NMO in the adults.
Yes.
Bilateral.
Common with NMO, but very uncommon in MS.
More common with Morg.
Yeah, I mean non-MS. Yeah. Right. So excellent. We're absolutely on time. So we go on to the second topic. CIS and early relapsing multiple sclerosis. Dr. Reshik with Dr. Vinaya and Dr. M.A. Khan. Reshik, you want to put up your slides?
Hello, good morning, sir. Am I audible?
Yes, Reshik, you're audible.
Yes.
Can we see your slides, please?
Yes, I'll share the screen. Is it visible?
Yeah. Yes, I think if you go on the slideshow mode.
Yes, sir. Yes, sir.
Yeah, that's perfect.
Good morning, everyone. So today we are going to discuss about clinically isolated syndrome and early relapsing MS. Starting with introduction, clinically isolated syndrome episodes are mild and they usually recover completely. Prediction of long-term course of clinically isolated syndrome is challenging, where 85% will be diagnosed with MS once evidence for dissemination of lesions in space and time accumulates. Therefore, it is important to understand the natural course of CIS to balance the potential benefits and adverse effects of disease-modifying therapy. Coming to definition, it's a monophasic clinical episode where patient reporting symptoms of objective findings reflecting focal or multifocal lesions, which represents inflammatory demyelinating event in central nervous system. They may present acutely or subacutely, and the duration of the symptoms should at least last for 24 hours with or without recovery. There should be absence of fever or infection. And these episodes are similar to MS relapse, but in a patient not known to have multiple sclerosis. And in the box, we have mentioned the typical presentation of a clinically isolated syndrome, that is unilateral optic neuritis, focal supratentorial syndrome, focal brainstem or cerebellar syndrome, and partial myelopathy. So this chart shows that the possible transition of clinically isolated syndrome during the disease progression, where it may remain in the clinical isolated syndrome state, or it may progress to have relapsing remitting MS or secondary progressive multiple sclerosis. Several controlled studies have shown that conversion to MS can be delayed by starting drug modifying therapies at clinically isolated syndrome stage. One of the study is Benefit CIS trial, which was started in 2005, which is a prospective international multi-center randomized double-blind placebo-controlled study. It's a 5-year core and follow-up study, which was decided later to conduct a prospective comprehensive 11-year cross-sectional reassessment. This was a study which was done to assess outcomes for patients treated with interferon beta 1b immediately after CIS. So 278 patients of the original 468 patients were enrolled, in which early treatment was given in 167 patients with interferon beta 1b, and 111 patients were given delayed treatment. After 2 years or conversion to clinically definite multiple sclerosis, all patients could have treatment with interferon beta 1b, but could also take another or no DMT. After 11 years of assessment, they found that the risk of clinically definite multiple sclerosis remained lower in the early treatment arm compared with the delayed eye treatment. The risk of conversion to CDMS was still reduced by 33% for patients in the early treatment arm related to those in the delayed treatment arm. The overall annual relapse rate was lower in the earlier treatment group than in the delayed treatment group, resulting in a 19.1 reduction in risk of relapses. This long-term follow-up study with class 4 evidence showed that the time to CDMS was prolonged. Additional clinical measures like annual relapse rate was improved by early treatment, while both groups showed a generally mild disease course. And also early treatment with interferon beta 1b had a long-lasting beneficial effect on disease activity, as well as cognitive outcomes, resource utilization, and employment rate. This is another study on natural course of clinically isolated syndrome, a longitudinal analysis using a Markov model. So they constructed a Markov model to simulate the natural course of clinically isolated syndrome. So Markov model is actually a method which is used to predict the next state with the help of the current available data and the probability of the probabilities, which is with the help of the current available data. So they estimated the probabilities of transition of CIS to more advanced disease with the help of the Markov model. And the study showed that more than 85% of the subjects with a diagnosis of CIS progressed to RRMS, and the reduction of life expectancy in subjects with CIS is marginal. These were the different studies in which Markov model study was used. As we can see here, these were the patients who had clinically isolated syndrome in the initial status at the beginning of the study. And these were the patients who had RRMS in the initial of the study and SPMS. So the next table, these are the published studies in which we can see in this Dr. Riordan studies, where patient initially who had clinically isolated syndrome were 81, out of which after 10 years of follow-up, 29 remained in the clinically isolated syndrome, whereas 39 had progressed to RRMS and 12 had progressed to SPMS. So this study, these published study provided the 10-year transition data, and also probabilities were obtained from the published studies. In the study, this graph shows that the percentage of the subjects at each stage of the disease stages at varying time. As we can see that the proportion of clinically isolated patients declined over time in an exponential manner. Also, most of the patient transition to relapsing remitting MS in the second and third decade. And also in the fourth and fifth decade, we can see that the proportion of secondary progressive multiple sclerosis increased. Therefore, the study stated that the clinically isolated syndrome significantly reduces quality of life, but also has little impact on overall survival of the patients. Better predictors of long-term prognosis were urgently needed to enable early targeting of treatment for patients who will benefit with the long-term management. Now, diagnosis and management. The clinically isolated syndrome subcategories based on MRI or clinical evidence. The clinical findings were monofocal or multifocal. So type 1, which involves monofocal presentation with at least one asymptomatic MRI lesion. Type 2 were multifocal presentation with at least one asymptomatic MRI lesion. Type 3 were monofocal presentation with normal appearing MRI. 4 was multifocal presentation with normal appearing MRI. And 5 was MRI suggestive of MS, but no clinical presentation suggesting demyelinating disease. So diagnostic evaluation and assessment of early prognostic factors will likely dominate clinical activities at the initial statement. These were the factors which were associated with worst outcomes, which involved smoking, low serum vitamin D levels, obesity, and comorbid cardiovascular disease. This table shows the risk of disease activity in clinically isolated syndrome and early multiple sclerosis. As we can see, in the low risk group are the patients which have clinically isolated syndrome with a normal brain MRI where treatment is not indicated. In the medium risk group are the radiologically isolated syndrome with higher risk of spinal cord lesion of positive oligoclonal bands. Also, RRMS without relapses or new MRI activity over the previous 2 years. And the high risk groups involves clinically isolated syndrome with 2 or more T2 lesions more than 3 mm in diameter on MRI brain, and higher risk in smokers, those younger patients with less than 30 years of age, and those with low serum vitamin D levels where treatment is indicated. And also very high risk groups which are single attack and meets the diagnostic criteria of MS. Highest risk if 2 or more enhancing lesions on brain MRI, clinically isolated syndrome phenotype followed by new disease activity on brain MRI, and RRMS with 2 or more inflammatory events within the previous 2 years. In clinically isolated syndrome, the chance of new clinical or MRI activity is 60 to 70% within 6 months and 80 to 90% within 2 years. Features that identify those at greater risk of future disease activity are younger age of onset, presence of enhancing lesions, or 9 or more 2T lesions in the initial MRI brain, and presence of CSF oligoclonal. A very low risk of future relapses are patients with optic neuritis and those with a normal brain MRI. 90% of patients with CIS who develop a new T2 lesion during follow-up will have a second attack within 3 years of the initial attack. These are the factors which can lead to worse long-term prognosis, which involves onset after 30 age, male gender, non-white race, motor or cerebellar onset, poor relapse recovery, frequent early attacks, and presence of CSF oligoclonal. Also, factors like comorbid cardiovascular disease, low baseline vitamin D levels, and higher burden of disease, presence of brain atrophy as well. and ongoing disease activity. The only patients with CIS who will not benefit with drug modifying therapies are CIS with normal MRI or CIS or relapse RRMS with no active disease in the previous 2 years. These patients need to have annual MRI monitoring in 5 years, and DMT should be offered to patients with CIS with with MRI abnormalities suggestive of MS, and untreated patients with RRMS who have had disease activity within previous 2 years. Coming to infections and relapses, infection can also trigger relapses, and they can also trigger pseudo relapses. Pseudo relapses are when fever or another stress unmasks previous neurological injuries. The previous injury may have been from a prior relapse from lesions previously detected only by MRI. And the patients with CIS should report all new symptoms so that we can differentiate between relapses and pseudo relapses. First-line treatment options. The disease-modifying therapy may be classified by mode of administration of the first line or second line. Approved first-line DMTs include both injectable and oral forms. The injectable therapies are interferon beta and glatiramer acetate. Both interferon beta and glatiramer acetate reduces the chance of further activity and also reduces disseminity accumulation. Common side effects of interferon beta are flu-like symptoms, and mainly the interferon beta requires lab monitoring, whereas in glatiramer acid, there is no need of any lab monitoring, and side effects include shortness of breath, chest pain, diaphoresis, and syncope. Oral therapies, they're convenient, they are relatively new and cause immune suppression. Long-term safety is a concern. First line oral therapies include dimethyl fumarate and teriflunomide. Both of them reduces disease activity and disability accumulation. In the dimethyl fumarate, immune suppression is a common side effect, whereas here severe fetal abnormalities is the main side effect of teriflunomide. And monitoring needs in teriflunomide is hypertension and monitoring of peripheral neuropathy. Potential lymphopenia needs to be monitored, and liver toxicity. And here in dimethyl fumarate, we need to look for lymphopenia and liver functions. Minocycline. It is an inexpensive, widely available, safe, and reasonably well-tolerated drug. It can be considered as a bridging therapy when therapy initiation may be delayed for many reasons. In 2017 phase 3 randomized placebo-controlled clinical trial, minocycline 100 mg 2 times a day reduced the chance of reaching an MS diagnosis at 6 months by 27.6%. The common side effects are dizziness, nausea, diarrhea, abdominal pain, and skin rash. Lab monitoring requires liver function. As patients with CIS recover, drug-modifying therapy for CIS remains controversial. Hence, four large-scale blinded studies have been conducted to evaluate drug-modifying therapy affecting conversion of CIS to CDMS. So these are the four trials. First one is the CHAMPS trial, which is a 3-year study, which involved a study of 382 patients. Here, as we see that 50% of the patient after the study showed conversion to clinically definite MS, and the patient who received interferon beta 1A, 35% of patients converted to CDMS. PRECISE trial, which is again a three-year trial study, which involves 382 patients who received glatiramer acetate, and out of which 43% of patients were converted to CDMS among the placebo group, and the patients who received treatment, only 25% were converted into CDMS. Benefit trial, I have explained benefit trial in detail. And ETOMS trial, which is a 2-year study and involved 225 patients, in which 45% of the patients who received placebo were converted to CDMS, and 34 patients who received treatment were converted to clinically definite multiple sclerosis. Now, deciding on treatment. To decide on treatment, we need to know the natural history of multiple sclerosis. We need to identify the prognostic factors of an individual patient, understand the risk and benefits of the various drug-modified therapies, determine the patient's specific risk for each treatment, considering competing philosophies about the best approach to treatment initiation, which includes escalation approach, highly effective therapy, and induction approach. It is important to discuss treatment option with patients in a process of shared decision making to incorporate their preferences into treatment recommendation. Escalation approach is the most common one, in which low risk often less effective therapy are started first. Effective for many individuals and the risk are lower. Treatment escalation is considered when intolerance or treatment failure is encountered. Highly effective therapy is an alternative approach used when the consequences of treatment failure are severe enough that the greater treatment risk is worth taking. Most appropriate for patients with worse long-term prognosis, and this needs to be discussed with the patients. Induction approach is a risky but highly effective therapy to settle disease activity, followed by lower risk, lower risk, which is a less efficacious therapy. The main treatment categories and differentiating features should also be explained. Common issues that narrow treatment options include pregnancy planning, comorbidities, concomitant medications, willingness to consider injectable therapy, and willingness to accept this uncertain long-term risk that come with newer treatment choices. Regarding treatment options, this could be presented to patient as injectable therapies, which have the longest safety record, oral first-line therapies, which are more convenient but have less long-term safety, second-line therapies, which are more likely to stabilize the disease but have higher treatment risks, so are often considered if an initial therapy fails. 2 or 3 disease-modifying therapy options will remain for further discussion. Interferon beta and glutamate acid can initially be discussed as a class of therapy, and delays in drug-modifying therapy should be avoided. Risk of reaching an EDSS score of 4.0 is increased by 7.4% for every year of delay in treatment initiation after MS onset. So key points are that the patient with clinically isolated syndrome over a given time interval may remain in the clinically isolated state, progress to RRMS or SPMS state. Studies on drug-modifying therapies in clinically isolated patients, that is, these 4 trials, CHAMPS trial, PRECISE, BENEFIT, and ETOMS, have supported the evidence that early treatment improves the outcome. Minocycline can be considered as a bridging therapy when the therapy initiation may be delayed. Assessing factors with poor outcomes and categorizing patients in a risk group is an important part in managing patients. All the treatment approaches, which includes escalation approach, highly effective, and induction approach, should be explained to patients with CIS before initiating therapy. Thank you.
Thank you very much. If you can stop sharing your screen.
Yes, sir.
Yeah, I think Reshik has outlined the CIS very well. I think as a clinician, when you see the patient early, there is more problem. When the disease has announced itself better, then you know better what to do. So maybe we'll invite comments from the experts, Dr. Vinaya and then Dr. Khan, and then open it for discussion. Vinaya?
Yes, sir. So he's presented like everything like in great detail. The main points is identifying the patient, the risk factors. Basically, the table was important that patients with very high risk and high risk are considered to be. We should consider early treatment in those cases with CIS, who fit into the very high risk and high risk criteria. And the point was the minocycline trial, I think is striking. We've never like used minocycline in India, but there is a trial, it's a Canadian trial which was conducted, and they have said that it's like a bridging therapy. If there's any delay in starting the disease modifying disease modifying therapy, I think minocycline could be considered in these patients. Yeah.
Can we request Dr. Khan for his comments? So you're on mute. It's still on mute.
Go down to the lower left hand corner. Hasmina will help you. Satish, in the
Yes.
meantime,
Yes.
can I ask
Yeah. In the meantime, can we? Yes.
can I ask a question to Dr. Singhal
Sir, please.
because of his vast experience? So, how often have you started interferons or disease modifying therapies in cases of CIS in India? And
I
is the
think
pattern of CIS in India similar to the pattern of CIS in the Western world where MS is more common?
I think it might depend on the clinical presentation, really, Sarosh.
Yeah,
But nowadays, the number of cases that you see as CIS are diminishing. Majority of the cases really turn out to have, actually, because of the modified criteria of McDonald, many of the cases, when they present to me, at least, have turned out to be multiple sclerosis now. And even in the trial, which was mentioned, the long-term trial, CIS meant really presentation with the first symptom, but also 2 or 3 lesions in the brain, which was asymptomatic. They were not single isolated case, unless you had. So I feel that majority of the cases, CIS by themselves, if they're presenting with a single, if the lesion is not very disabling and the patient is recovering, I don't think I really offer them. I discuss with them the possibility. The majority of the patients are reluctant to take the treatment. I didn't have any patient really who needed a induction therapy in the phase of the clinically isolated syndrome.
fine.
Maybe we
And
can go. Yeah. Yes.
this problem was there initially when the cost of the interferons and all these disease modifying therapies were very high. Nowadays, as the costs have reduced, I think the neurologists feel more comfortable to discuss these things with patients.
Absolutely. But the patients are quite reluctant to begin. They always ask you how long will I have to take the medication.
Yeah.
What is the answer you give?
Maybe we can go to Dr. Khan for his comments, and then I have one question for everyone. Yes.
I agree that while the CIS is probably a robust entity, the space is contracting. And this is because of the increased sensitivity of the tests which have been put in the revised classification. And so that that space will automatically contract, and there'll be earlier diagnosis of the relapsing, remitting, or clinically definite MS. However, there is still a great pressure on neurologists to make an accurate diagnosis in order to be able to consider the classification as has been said. This means that starting DMT inappropriately may be harmful for patients, say, with NMO. Response might be after due consideration. And of course, now, since DMT is much less expensive, as Sarosh was saying, there is a great temptation to use it soon or quickly. But I think that probably many times we have to consider much more carefully about the patients in which it is used.
Yeah.
I think radiological isolated syndromes seem to be more common than CIS, at least with the plethora of MRIs that we are having in Mumbai.
Sarosh, the other thing is, have to be given the choice to the patient. No? Would the patient would be willing to take the treatment?
Right.
Majority of them will say no. At least that's in my experience.
You know, in the benefit that we showed just now, at the end of 11 years, 71% of patients were still taking their injections. I can't imagine our patients taking injections.
Absolutely, absolutely.
Yeah.
I had only one patient who continued really right from the inception for 25 years. But she also had diabetes, type 1. Nadim was seeing her. And she, of course, continued the Evonex.
Satish, your question.
Maybe I can put it up now or after the treatment. The question is like this, that at one end, conventionally, we have been conservative clinicians and say, okay, what is the disability? What is the symptom? And then design the treatment accordingly. And if there is more trouble, we will give bigger one. So that conventional approach, which has safety in mind and a certain degree of, what shall I say, defeatist attitude along with it, it seems to be replaced by a very aggressive approach, where at the word go, when the lesion is inflammatory, not yet turned degenerative, may it be CIS or may it be early MS, you hit with the best you have and you accept the side effects that will come. Like Dr. Singhal said, patients' participation, of course, in every case will decide which treatment. But I am unable to decide which approach looks more logical at this stage of knowledge and this stage of understanding of the process. I know there is no answer to this, but the views welcome.
I think some of the neurologists believe in now, hit early, hit hard.
Correct. That's where it is going.
And I'll quote Nasli Ichaporia will go straight off for alentuzumab, eculizumab, to treat the disease aggressively, particularly if there are many relapses in the first 6 months.
So, Rosh, here you are discussing CIS, no?
No, sir, I put the question up for both, sir. CIS and early MS.
No, early MS, it's an aggressive MS, yes.
Aggressive MS, early mild MS, there are so many variations. So I think this question can be taken up subsequently also.
Yes. Yes.
But
I think the mindset of the doctor probably is as important as the mindset of the patient in this particular situation, as to whether you're going to go aggressive or whether you're going to go conservative. Or
I have one answer to you.
Yeah.
Okay. Above the age of 65, the neurologists tend to be conservative. They will tend to be slightly more aggressive, particularly if they are below 50. This is but they have come at a stage when the medications are less expensive, more easily available.
Yes.
We were treating our patients when the expenses of the medication were so high that we had the natural history of the disease.
Correct. Correct.
Sarosh, they are starting a registry. Rohit Bhatia has taken the lead. So we also have to know how the Indian patient responds, because I'm quite sure you have had patients who have been following up for 15, 16 years, and they remain quite well.
Exactly,
and
sir.
Against the question
that adds to the dilemma.
Pardon? Yeah.
That adds to the dilemma.
So also, sir, I had a question about minocycline, the trial, which was done. Should in Indian scenario, in our patient, should we be trying minocycline? Just a question. I read about the trial and it was new to me, so I was just wondering.
You never used it. Rosh and Satish might have. I've never used it.
No, neither.
Nor is it discussed much by the MS experts in the international meeting.
My only comment is minocycline seems to enter so many therapies, so many different diseases that I don't understand why it is tried for so many different things.
Yeah.
Yeah.
Thank
So
you.
do we move on to the next one? Yeah.
Yes.
So can we have the next presenter, please? Dr. Rajesh
Yes, sir.
Benny is going to be the expert. Rajesh,
Rajesh,
welcome.
welcome. Thank you, sir.
Thank you, sir. Good morning.
Sir,
Good
my
morning. Good.
hello, good morning, everyone. So my screen is visible.
Yes, Vikas.
Yes, Vikas.
Vikas, you work in Fortis, no?
Yes, sir. Yes. Hello.
Yeah.
Is audible?
Yeah.
So
yeah, you're audible. Your screen is visible. Your screen is visible.
okay.
So go ahead.
Good morning, everyone.
So go ahead.
So first of all, thank you to Dr. Saras Kathak to giving me the opportunity to present the topic in the Continuum series. Myself is Vikas Patel, and I am the second year neuro registrar in the Fortis. And today my topic is highly aggressive multiple sclerosis under the guidance of Dr. Rajesh Benny.
You don't have to thank. You don't have to thank me. We want more and more
Yes.
postgraduates participate in this activity.
Sure, sir. So I will discuss the in following slides about aggressive multiple sclerosis, why it is important to detect this aggressive MS at an early stage, risk factors for aggressive form of multiple sclerosis, and how to diagnose aggressive multiple sclerosis on the basis of the clinical and radiological criteria, and treatment options available for treatment of aggressive MS and related complications. So first of all, the risk factors of aggressive multiple sclerosis. Non-modifiable risk factors, as we all know, is the male sex, age more than 40 years, and non-white race, and smoking. So even though the female has more demyelinating disease, but the age match male counterparts has achieved the disability milestone earlier than the same age female, and the clinical scenario, the frequent relapse, if the patients had one episodes even within the first year, the risk is double, and if the two episodes, the risk for aggressive MS is triple for the aggressive multiple sclerosis. The short inter-attack intervals, like between two attacks, the duration is less than 2 years. The walking difficulty starts earlier, 6.6 years, and for if the between two intervals the duration is more than 5 years, the aggressive multiple sclerosis, the chances of disability occurs after the 15 years. The other factors which we predict for aggressive multiple sclerosis is the incomplete recovery with residual weakness, and the disease with progress since onset. Rapidly worsening disability, the initial 24 months with initial symptoms like corticospinal tract involvement, and the cerebellar involvement has subsequently four times and 2 times higher rates of aggressive multiple sclerosis compared to counterpart of relapsing remitting aggressive multiple sclerosis. The location of the lesion, like the spinal cord lesions and the infratemporal lesions, has also the high risk of aggressive multiple sclerosis compared to relapsing remitting multiple sclerosis. So coming to MRI findings, disability at the 20 years after the disease onset are 50% for T2 lesions more than 5 to 9, T2 lesions 5 to 9 numbers, and if the T2 lesions is more than 10%, the disability at 20 years are almost 65%, while the T2 lesions less than 4 or less than 4 has a disability achieves at 15 years of age at almost 36%. The number of new T2 lesions or new enhancing lesions followed are the best predictor of future disability. As I discussed, the spinal cord and infratemporal locations are correlated with best with the future disability. The other findings is the CSF oligonal blends and CSF immunoglobulins index, and recently neurofilament light chain in the CSF correlate with the extended disability status scale score. But the neurofilament light chain is not commercially available. So based on the clinical relapse, disability, and MRI findings, the three schema proposed: the multiple sclerosis decision model, second is the modified Rio score, and third is Canadian working force. Out of these three, the multiple sclerosis decision model is the most sensitive, but which includes also above mentioned three criteria along with neuropsychology criteria. It's very sensitive, but the scoring system is complex, and due to this complexity, this less use at present. It includes all 4 domains, and it's which all are color coded on the basis of the points, and any red color domain in any one of out of 4, any 2 yellow domains, or any red color and any 2 yellow domains are requirement of immediate change of therapy, and should be modified. These patients should be treated with a disease modifying agents. Second scheme is Canadian working group. It's based on the clinical relapse, disability, and the relapse. The point system categorized as low, medium, and high level of concerns. Any low level of any high level of concerns, 2 medium level of concerns, or all 3 low level of concerns recommends the switching to more aggressive therapy. So most simplest method is modified Rio score to define the aggressive form of multiple sclerosis. It depends only 2 criteria: the relapse and the MRI findings. MRI findings at 4 or less than 4 new T2 lesions or enhancing lesions is 0.0, and more than 4 new T2 lesions is given to 0.1 at the MRI done at the 1 year, and the relapse over 1 year is 0 relapse for 0 relapse 0 points, 1 relapse for 1 points. So if the total cumulative modified Rio score is 0, the chances of the aggressive multiple sclerosis is 24%, while the score is 1, then the aggressive multiple sclerosis percentage is 33%, and the risk is almost double if the Rio score is 2. The Rio score sensitivity is less, but it's due to simplicity, it's useful. So coming to management options for aggressive form of multiple sclerosis, and disease modifying drugs available at present. So at present, there are 7 FDA approved drugs for the aggressive form. Is the efficacy wise, first is natalizumab, alimentazumab, fingolimod, siponimod, and ocrelizumab. Then the cladribine, then mitozentron, and declizumab. Last 2 drugs are rarely used due to some side effects. The off-label drugs are cyclophosphamide and rituximab, and most aggressive disease modifying agents at present for the aggressive multiple sclerosis is high dose immunosuppressive medications with stem cell transplantation, beam therapy with anti-thymocyte globulins. These drugs have higher efficacy in the aggressive form, but it also had more higher side effects So we have to use these drugs judiciously. Otherwise, the complications can occur more frequently than other patients. So the main task is how to select the patients for the which drug is to select for particular patients. The first I discussed to natalizumab. And the mechanism of action is it binds to the alpha 4 subunit of the complementary proteins, which prevent the diapedesis and the exit of WBC from the bloodstream. The natalizumab is supported by the two trials, AFAM and Sentinel trials. Both suggest of efficacy and safety of natalizumab. Compare and it's non-inferior to interferon gamma. The dose of natalizumab is 300 milligram intravenous every 4 weekly. The problem is main side effects related to natalizumab is progressive multiple leukoencephalopathy. It's caused by the JC virus due to the neutrophilic effects of the oligodendrocytes and inflammatory reactions which increase the cytokines. How to detect with PML so in MRI flare sequence it suggests of sharp border at the gray white junctions, and it's confirmed by the CSF polymerase chain reaction test. Risk of PML depends on the mainly 3 criteria: the duration of the natalizumab, the prior immunosuppressive use, and the JC virus antibody index in the CSF. The side effects other than the opportunistic infections and low leukocytes count, the rebound can occur after the last dose of natalizumab. So is advised to start any other disease modifying drugs before 4 weeks after the last dose of natalizumab. The second drug is alimentizumab. It binds to the CD52 immunoglobulins 1 monoclonal binds antibody and lies the lymphocytes, the dendrite cells, and decrease the Th1 and Th17 cells. The CARE multiple sclerosis 1 and CARE multiple sclerosis style 2 both are supported in these drugs and prove its efficacy in the aggressive form of multiple sclerosis. The side effects related to these drugs are infusion site reactions, opportunistic infections like herpes varicella and liver toxicity. It's better to pre-medicate with steroid, cetirizine, and give acyclovir as a prophylaxis for herpes simplex, and do complete blood count, creatinine, urine analysis at starting of alimentizumab and then after every monthly. Its other side effects related to alimentizumab is autoimmune disease like the Graves' disease, immunothrombocytopenic purpura, and chronic inflammatory demyelinating polyneuropathy and AIDP. Third drug is fingolimod and the siponimod. Both drugs acts on the sphingosine 1-phosphate receptors subtype. Fingolimod bind to all receptor subtype except receptor 2, while the siponimod only binds to the subtype 1 and 5. It acts by the binding the sphingosine 1-phosphate receptors and acts on its receptors present only the naive and central memory lymphocytes. So the matured lymphocytes cannot represent these receptors. So total circulatory lymphocyte count is directly not related with this drug efficacy or side effects. The freedom 2 and transform trials supports its use in the aggressive form, and for siponimod expand trial supports its use in the secondary progressive multiple sclerosis. The interesting side effect related to fingolimod is it can cause the bradycardia by the binding of sphingosine 1 phosphate receptors present on the cardiac tissue. Is due to its agonistic effect to this particular receptors over the heart, it produces the bradycardia, which peaks around 5 to 6 hours after that first dose of fingolimod, and then after the 14 days, the this receptors surface level is totally gone. So the ECG monitoring and the QT interval monitoring is required for this drug, especially used when on the first time. If you stop these medications after at least for 14 days, the receptors is again come to the surface level of the cardiac tissue, and so you have to monitor like as the first dose of fingolimod. Simultaneously, it can cause the macular edema, posterior reversible encephalopathy syndrome, and progressive multiple leukoencephalopathy. So, but in this, due to side effects of fingolimod, the PML, it's not predict by the lymphocyte count, and even not count by the JC virus index as compared to natalizumab. The side effects is macular edema, so you have to check routine checkup of eye examinations and optokine and the CBC, herpes titer, and creatinine should be done before starting the fingolimod. The daily dose of fingolimod is 0.5 milligram per day, while siponimod is the 2 milligram per day. The next drug is ocrelizumab. It's bind to the CD20 receptors, which lies the lymphocytes and also inhibit the T cell activation by inhibiting the cytokines. It has also the role on the inhibition of the B cells. And Opera 1 and Opera 2 trial supports its use. And the side effect related to ocrelizumab is infusion site reactions, flushing, throat irritations. Hypogammaglobulinemia can cause infections like hepatitis, herpes, and varicella. It's also the blood and breast malignancies also occur in very few cases in the ocrelizumab uses. The dose of ocrelizumab is first course given 2 doses of 300 milligrams 2 weeks apart, and then then 600 milligram every 6 months.
Okay, leave it. Okay, leave
so next drug is cladribine, is the chemotherapy drugs. It's a purine analog which breaks the single stranded DNA leads to death of lymphocytes and the monocytes. There is Clarity and the Oracle multiple sclerosis trial proves its efficacy. The side effect related to cladribine is even its chemotherapy drugs, it can cause the malignancy, and its teratogenicity cannot, and infections due to the leukopenia, the herpes simplex, varicella, opportunistic infections like mycobacterium avium complex, it's more while using these medications. Myocarditis and liver failure are also reported as the side effects. The dose of cladribine is 1.75 milligram per kg per year. So it's taken as the 10 to 20 milligram tablets, 10 milligram per day for 5 days orally in first week and then the 5th week, and repeat the same dose in the next year. Last two drugs is FDA approval is mitozentron. It blocks the topoisomerase 2 and disrupt the DNA replications. The side effects is cardiotoxicity and due to etiological factors for acute myelogenous leukemia. It's readily used now. This last drug is diclizumab. It's withdrawn due to the inflammatory meningitis and the liver failure. So coming to off-label drugs, the cyclophosphamide and the rituximab. So cyclophosphamide is alkylating agents which cross-links the DNA and stimulate the apoptosis independent death of cell. The dose of cyclophosphamide is 600 milligram per meter square, always given with steroids, 1 gram methylprednisolone for the 5 days, followed by the every alternative month till 2 years. The lifetime dose, maximum dose for cyclophosphamide is 100 gram because of its side effects, mostly the hemorrhagic cystitis and syndrome of inappropriate antidiuretic hormone, the myelosuppression and ototoxicity. The next drug is rituximab. Its a mechanism of action is to its binds to the CD20 antibody, and it's it's more immunogenic than the ocrelizumab, and it's more complement dependent. But it's used widely due to its low cost, and Hermes trial proves its efficacy. But still now the FDA approval is not there. So at present scenario, the most aggressive therapy for the aggressive multiple sclerosis is the high dose immunosuppressive with stem cell transplantation. The most preferred regime is the beam plus antithymocyte globulin, which intermediate myeloablation. In this procedure, the first mobilization of the stem cell by the giving the sergomopristim or filgrastim of GCSF, and then the conditioning regimen is applied, then the infusion of the stem cells and the reconstitution of the bone marrow. According to Canadian study, it's given the activity-free multiple sclerosis is multiple sclerosis in 70% at the 3 years, and the best results is seen in the young patients with no more than 2 prior therapy failed. So in conclusion, the take-home message is the first and foremost is the patient's participation is must to treat MS. We have to give all options to all available options to the patients, and then the final decision of patients. It's important to detect aggressive form early because this at present the treatment is available, and we can limit the residual weakness and the further complications. Switching to more aggressive therapy if present with breakthrough disease like the increase the EDSS score and multiple sclerosis functional composite. And the third, monitoring and the sequential follow-up is required to detect the side effects related to medications or any prognostic factors of multiple sclerosis. Thank you.
Thank you. Thank you. Thank you. Thank you very much. Thank you very much, Vikas. Can we invite Dr. Rajesh Benny to give his comments?
Thank you, sir. Thank you, sir. Vikas, can you stop sharing your slide?
One.
So Vikas has more or less covered everything that we would need to know about aggressive MS, and like the discussion which happened before with your last question, whether we should be very aggressive or we should be conservative neurologists. Now, my experience being a neurologist is limited as compared to you all. I'm just 13 years into practice, but I can see a big sea of difference in this last 13 years. When I started, I was a very conservative neurologist. So I would discuss, I would be reluctant. I would wait for the MRI to have some new changes. I would like to make the patient beg for the disease modifying drug before me actually implying that these should be taken up front. But 5 years down the line, when all the drugs start coming down, you see that it's not very difficult to sell these drugs. And we start understanding the disease better. Literature is pouring in about the aggressive forms, which you can detect early, and the red flags. And in the last 5 years, definitely most of us, like Dr. Khadilkar, Dr. Katrak sir was also rightly saying, those who are less than 65 are stepping up into the gear 6 mode. So we are really pushing hard for those with especially aggressive disease. So I think choosing the patients is important. So you see any patient who's having very frequent relapses, probably more than 2 in a year, a single relapse which is so disabling that you know that the EDSS is going to go to 3 or 4, making him go to a stick or in a wheelchair very rapidly in the next 1 to 2 years. Those whose MRIs are worsening, though they may not be clinically worsening, and these patients definitely will attack aggressively. Now, the choice of drug in this group, as we all know, becomes limited as compared to the ones where we have the more conservative approach. So this therapy, we call it the induction therapy. So induction therapy is when I will use it upfront in a treatment naive patient. So I have not tried any drugs in these patients. So here probably I would like to sell rituximab much more than any of the other FDA approved drugs. And we know by experience, I'm sure, we are leaning heavily with Dr. Singalsar's experience on rituximab, that rituximab definitely has a very big role in these patients with aggressive MS. Side effect profile is very, very acceptable if you carefully monitor them. And the treatment duration is only once in 6 months. So probably the approach that I followed in the last 3 years is to hit them hard, especially those with aggressive MS, first 2 to 3 years with rituximab, and then switch down to a first line therapy, oral drug or probably an interferon beta 1A like Ivonix. And that seems to work, that seems to get the relapses down. There are those odd patients who still worsen. And probably those are the ones where natalizumab has been used by me probably once or maximum twice. I have never used stem cell therapy, but that looks being used more and more. And like I was discussing with my hemat colleagues, especially people in North India are preferring more and more of stem cells very quickly in those with aggressive MS. So with this comment, I would like to ask a question to all the seniors, including Dr. Katrak, Dr. Singhal, Dr. Khadilkar sir, Dr. Sirsat, that what is your experience with stem cells in very aggressive MS?
I'll answer that question very easily. 0. I don't have any.
Same here.
Dr. Singhal sir?
At the Fortis Hospital, the neurologist practicing over there, they have a largest experience probably in India.
Yes, sir.
Of about 25 cases.
Yes, sir. The FMRI at Gurgaon.
Yeah.
FMRI at Gurgaon.
By Fortis in Gurgaon.
Yes, sir.
I don't think many other centers are doing it, and I think it requires a very good center. There are centers in, but to offer this therapy, there are centers in Moscow. One of my patients went there. He has had a progressive MS, and he has benefited marginally, of course. But I think there are centers in Canada, Toronto. I think, wherever, and there's also centers in England. But I think they consider consider all pros and cons before offering the treatment.
Yes, sir.
My feeling is the other drugs are being used more extensively, but perhaps cletibine and lemtizumab are being more used in England. And rituximab, of course, is our choice. In America, they're using ocrelizumab and not rituximab because of the insurance coverage. And the first-line drugs are being used more frequently because of the cost, in the generic drugs. That's the reason, because the cost is another limiting factor for the use of the first line when we are using but the costs have come down considerably. That has been another factor which has made people take the medication, but after 2 years, they always ask, how long do I have to continue this? Do they ask you this question?
Every time.
So that is the problem.
The other question is that at one time we were on mitoxantrone, yes, because it was available, and then we moved on to rituximab. So you've seen both the drugs. So you think rituximab is a better alternative compared to mitoxantrone from personal?
I'll explain to you, Satish. We used in 21 patients. And the first patient was extremely poor and quite disabled, has done extremely well. Mitoxantrone might still be a choice for a person who is disabled and secondary progressive. I think the rituximab is good for prevention of new episodes. Or where the person is getting disabled, mitoxantrone might still be considered. One of my Canadian colleagues, considers this use of this drug more often in secondary progressive ones, those who are getting disabled. So if the EDS is extending beyond 4, they tend to use this drug. But of course, there are limitations. You can't use it for, beyond a certain period.
Yeah.
If I have to give it, I don't give for more than 3 monthly, 4 doses or 6 doses, but not the full dose.
Total dose being the limiting.
Yeah. But we are using more and more of rituximab as a first preference.
I mean, both are injections once in 3 to 6 months. So in a way, for the patient, they are similar in the way they need to come into the hospital. And
just for youngsters' sake, sir, because
with ocrelizumab.
Ocrelizumab, I think, the rituximab is as good.
Okay. But you have no experience with ocrelizumab?
No, one of my patients, who could really manage to go to America and took it, but I was no better. I think I discontinued it.
so medico-legally, how do we justify ourselves? Because these are technically off-label drugs which we are going to use for MS.
I don't think.
Rituximab.
Well, I think there's a large experience in Sweden.
Yes.
Yeah, so I feel that one can quote the studies, can't we?
Right.
And the FDA of India, I don't know what drugs India has approved and what drugs they have not approved.
Yeah.
We can't follow the FDA of America.
Okay.
Neither the Europeans follow the FDA of America.
Rajesh, may I just say one thing?
Yes, sir.
Have you been using Frisium?
Yes, sir.
It is not recognized by the American FDA for the treatment of epilepsy.
But sir, it's a harmless drug, sir. Rituximab, so the problem is when people land up with complications, sir.
Oh, I think the European Union uses rituximab.
Yes, yes, especially Sweden and also.
The gold standard is not the US FDA.
Yes, sir. Yes, sir.
Now we are looking at this continuum, which is an American publication.
Yes, sir. Yes, sir.
Therefore, they are bound to put up as off-label.
Yes, sir.
But there are so many off-label indications that we are using.
Yes, sir.
Sarosh, in America, they can't use it because it is the insurance coverage. Insurance coverage will only be for the approved drug.
Correct. I'm not saying no to that. I mean, they cannot use it and therefore they have to explain the off-label indication to the patient. But I think we have been using so many off-label, so-called American off-label indication. I think clobazam is a classical example. It has still not been approved by the FDA for the treatment of epilepsy.
Quite, absolutely.
Right.
I mean, one option is to get it cleared by the local ethics committee where we work. Ashok, you want to make a comment? We'll take that and then go to...
Sorry, Ashok, just one more comment. If you have an informed consent of the patient,
yes,
I think you have covered yourself properly.
Yes.
Correct. That's the point. Yeah.
Yes, Ashok, you want to?
No, that's the point. If the consent is taken, then that's true.
Yeah. So we go to the next one.
Yes.
Next, the speaker's name is not written here.
Yeah, that's me.
Yeah. Oh, okay. You're going to do it yourself. Yeah. So
right.
So the topic that Dr. Shirsit is going to cover is monitoring, switching, and stopping MS disease-modifying therapies.
Yeah. Is this better? Am I sharing okay?
Yes, visible and audible.
Yeah. Okay. Good morning, guys. We are trying to learn how to monitor, switch, and stop DMT in MS. Now, fortunately, what has happened for me, the previous two speakers, both Vikas and Rashik, have discussed individual medication. So the time has come to deal with the principles on how we are going to go about this problem. Why do we start what medication and how do we move about it? Now, why do we learn this topic? We have to learn everything about the DMTs available. What are the reasons to switch therapies from patient point of view and the physician's point of view? And what is the scientific basis behind this decision? More than the medications you have, more the side effects you have, and more the interactions you have. So you've got to learn about them. More the medication, more the choices, more the confusion. And we need to learn smartly to use the tests required for every situation we have. If you begin well, you've got a better chance to move on. So the first step of the diagnosis, the medical team must have a meeting with the patient. And this is unique to our society. The caregiver team. A caregiver need not be someone who lives with the patient, someone who takes care of the patient. It can even be an extended family. It can even be the medical officer of a large corporation like ONGC, Indian Oil, Hindustan Lever, the medical officer where the patient is working. So all these individuals have to be in the loop when we discuss with them. We need to discuss regarding monitoring the potential benefits, the short-term adverse effects, and the long-term risk before we start a drug. And then also discuss whether we have to change our decision regarding a particular drug. And finally, we have to answer the question, could we ever stop the treatment? So patients, caregiver, and physicians have an equal role to play here. There are some non-medical factors, money and cost, desire for pregnancy and lactation, and this question of adherence. Why are some patients more disciplined while some patients are not disciplined? Various studies have shown a 3 to 53% differences between this lack of adherence. Why is there a wide variation? Now, I think it could be lack of adequate patient education by the medical team. Sometimes patients are not aware of what they're going in for, what the disease is all about. So what are the models of treatment? What are the paradigms? The problem is different companies are making different drugs. So getting a straightforward, real-world head-to-head trial is almost impossible. Remember that any new symptoms on a DMT may not be a true worsening of the MS, but can be symptoms associated with a lesion, like paresthesia, fatigue, and need to be managed by other symptomatic medication. Presently, a new immunotherapy substitutes the old therapy, that is the principle of monotherapy, rather than polytherapy. We don't usually give two medications together anymore. But there has been one true trial, a combination therapy trial called CombiRex. In RRMS patients, interferon beta 1A plus datiramar acetate versus datiramar acetate alone. There is no clinical advantage between this combination. However, if the known therapies fail, then the recommendation by the scholars of MS is to advise the patient to enroll in a trial of newer experimental therapy. But there is a problem to this. Whenever the company is sponsoring a trial, they do not want severe, highly aggressive MSs. They want a little more quieter patients, people who don't have, probably preferably undiagnosed, patients who have not yet had any more immunosuppressant therapy to be enrolled in the trial. So there's a big problem involved there. One more strategy to combat adverse effects of medication. If the patient is stable, we can reduce the dose as in interferons and teriflunomide, or to make it alternate day, like fingolimod, to try and correct the lymphopenia if there's no Gard-Ignacy lesion. And natalizumab also you can reduce the dose by 50%. Who are JC virus positive. So what are the methods used to treat or how do you go about combating the disease? There are three established models. And let us analyze this. Let us analyze them as models. You have the escalation treatment paradigm. You start and go higher and higher, higher. And what is that? Look at this graph. On the colored part on the right-hand side, you have lower down, you have a low disease activity. High up, you have a high disease activity. In the square, You have the efficacy of the medication, and you have time. So at point of diagnosis, where the disease hopefully is not very aggressive, not very profound, not very well established, you have three choices: glatiramer acetate, interferon beta, and teriflunomide. As time goes by, if the disease gets more and more aggressive, you have two more choices. You have fingolimod and dimethyl fumarate. If the disease continues to progress in more time, you have two more choices. You have natalizumab and you have two anti-B cell therapies. And then when the disease gets very highly active, you have the choices are alemtuzumab, mitoxantrone, cyclophosphamide, and stem cell transformation. If the disease as time goes by becomes very mild, it becomes very low, then you can even discontinue DMT or go back to the first line therapy of glatiramer acetate, interferon beta, and teriflunomide. So this is the model where you go step by step depending on the time gone by and the severity of the disease. So start with low and go high. There is no pattern. There is no statement to make a head-to-head trial. There's no way of modeling that which is most aggressive and which is least aggressive, which is most effective, what is least effective. The relatively less effective injectable interferon, oral teriflunomide. Intermediate efficacy, fingolimod and dimethyl fumarate. And allegedly the most effective, natalizumab, ocrelizumab, and alemtuzumab. Now, what is our experience of this? If treatment with interferons and glatiramer acetate failed, then think about natalizumab. If interferon failed, then put on ocrelizumab, alemtuzumab, and in our world, rituximab. If you wish to switch from natalizumab, then think of injectable interferon. Then you think of fingolimod, or you think of rituximab, or you think of alemtuzumab, depending on what state the patient is in. The main argument against escalation approach. Ask yourself, what is the natural history of MS? More the overall lesion load, worse is the long-term prognosis. So why allow relapses in the first place? When you go for the second step, the induction maintenance treatment paradigm. This is something very, very aggressive, will not appeal to any one of us here. On day one, hit the patient with all the guns which you have. You hit them with alemtuzumab, mitoxantrone, cyclophosphamide, and stem cell transformation. As time goes by, the disease is still active, put them on fingolimod, dimethyl fumarate, teriflunomide, glatiramer acetate, interferon beta. Ask yourself a question. After all this, do they really need maintenance disease-modifying treatment? Well, if they don't, discontinue DMT. Or you keep them for DMT for some time. If it stabilizes and the disease becomes less active, you can discontinue DMT. So this is a concept of induction. It is copied from oncology. Hit the disease hardness at day one with mitoxantrone, cyclophosphamide at the beginning of the disease, and then go on for safer medication. But watch out for the risk of adverse effects. So now the most effective and then relatively safer alemtuzumab is playing a role. The new kids on the block, siponimod and claritidine, I don't know how they'll act in this stage. So on one extreme, you have something weak that goes on. Another extreme, you have something too strong and hit it hard. So is there a middle path to all this? Yes, there is. You can have a second generation at the first line. Make your diagnosis, and you start with either natalizumab and anti-B cell therapy. And that probably would appeal to many of us here because of our exposure to our unique situation. After some time, if it stabilizes, you discontinue the DMT. Possibly if you don't stabilize it, you go into more aggressive therapy. So this, as simply put, if the patient is DC-virus antibody negative, start with natalizumab, or if anti-CD20 DMT rituximab without de-escalation. Take a choice. What is the lesson to be learned? The lesson to be learned is decide who is the patient, how much is likely to cooperate, how much is likely to learn about the patient. Do you have the facilities to monitor the patient? Where are you? Where are the patients? What is the distance between you and the patient? Some of patients live very far away. So the decision of every patient has to be individualized. Here is the discussion of various individual drugs, and this has to be extensively covered in the past, starting with interferon beta, latinomor acetate, natalizumab. These details have already been discussed in the two previous slides. Now, the next question that I want to tackle is, how do you switch from one step to another? This is not evidence-based. This is again your individual bias, your individual, what you're used to managing. There is no standard definition of treatment failure. Many medications take time to start acting as they take time to get washed out. Please remember today, the aim of the therapy of MS is NEDA. It is not stabilizing the patient. It is no evidence of disease activity, either clinically or radiologically or by your labs. That is the way that should be your aim. What is the Rio score and a modified Rio score? Rio here is the name of a man and not the name of a city. Patients with new lesions at 1 year of treatment do worse clinically over the next 4.8 years. And this could be a clue as a need to escalate. So which means the more higher treatment paradigm in many patients has a greater role to play, especially they're showing lesions in 1 year after diagnosis. Before doing the next drug, give a proper drug-free washout period to prevent excess immunosuppression, to prevent lymphopenia and the risk of possibly life-threatening infection. And that has to be kept in mind. But if the washout period is too long, then there is a risk of flaring up of the disease. The exact duration between two drugs is not evidence-based, but between 4 to 12 weeks. Now, finally, the question that all patients are going to ask you at some point of the time, earlier rather than later, when do you stop DMTs? The most common causes to stop DMTs are drug intolerance, progressive disability due to lack of response, secondary progressive MS, which we are going to tackle. Older the age of onset, less is the efficacy of DMT. In RRMS patients, one could consider stopping DMT up to the age of 45 if no new lesions for 3 years. Now, is there any evidence for this statement? The answer is yes. We have the Institute database. Again, evidence-based medicine is clearly shown. Those patients who stop DMT after the age of 45 and had no clinical or MRI evidence of new lesions for 4 years prior had a 94% risk reduction of a new relapse compared to those below the age of 45 with the active lesions in the last 4 years. So in short, if you are given adequate treatment, patient is above the age of 45, and for 4 years he's had no active lesions, then consider stopping DMT. Now, thank you. This is from the book. Now, time and again, Dr. Kathrak and Dr. Khadilkar and Dr. Jimmy have made statements that these books are written for American audiences and American students. Is there anything else that we need to add for our people? What is current? What is current? So Dr. Kathrak has used this phrase of there is the elephant in the room. But Dr. Kathrak, I want to make it clear to you, in MS DMT, there are no elephants in the room. There is a whole herd of elephants at the corner of a watering hole. And these are the guys who are going to attack your DMT theories of management of MS. So what are the elephants that we have to tackle in this talk today? One is these 3 elephants, counting the dollars, the rupees, and the gold. Money. How much do these drugs, the DMTs, cost to a patient? Do we have any answer? This is the data I collected from the company, not from the chemist shop, directly from the RSM, from the regional sales manager and the MR. And they've been very, very helpful in giving me this data. So what is the data here? One sec. Yeah. You tackle interferon beta 1A. You start with 108,000. For PEG, the PEG interferon, with 198. For dimethyl fumarate, you have two drugs. You have 228 to 228,000 and 36,000. This per year cost in Indian rupees per patient. Natalizumab is 5 lakhs 4,000. Glatiramer acetate, 40 milligrams, 3 times a week dose, 96,000. Glatiramer acetate, please maintain, all the doses are irregular. You have 3 more drugs, teriflunomide, fingolimod, and rituximab. Now, rituximab is one company gives you a voucher to do free CD20 counts every 6 months. And patients are very happy to get that and have it for a fact. So if you see the cost structure for a patient, today the imported natalizumab would be the most expensive, followed by PEG interferon, and glatiramer acetate, followed by fairly similar cost structure for teriflunomide, rituximab, and fingolimod. After doing this, you have another elephant. 3 elephants balancing each other. How often we get this phone? The last phone I got was 11:30 last night. Doctor, can I take the vaccination? Especially for COVID-19. Now, for COVID-19 vaccination for Indian patients, there is no clear statement. So what do we know? So what is known for sure? And this is the paper in Nature Reviews Neurology 2012. In MS patients, vaccinations are very important as viral and bacterial infections are known to induce relapses and accelerated progression of MS. But the approach has to be cautious as the reports of potential harmful effects of vaccination. To summarize, inactivated vaccines are safe and beneficial, and immunosuppressive and immunomodulated treatment can affect vaccine efficacy. So that's where we are. This is the chart of all the vaccinations that can be given for MS patients. And I want to bring your attention to the typhoid fever. The inactivated vaccine, the intramuscular vaccine, is safe, while the live vaccine, which is oral, is unsafe in MS patients. So based on this data and some more data, we have a statement from the American Academy of Neurology saying all vaccines for COVID-19 are safe. And he's talking about Pfizer and Moderna. We must protect our patients with MS from COVID-19. Regarding the use of DMT and vaccines, there are some gray areas. Dimethyl fumarate, interferons, and natalizumab may be relatively more hazardous than glatiramer acetate and teriflunomide. So in the COVID epidemic for MS patients, teriflunomide may be the safest medication to give. The fingolimod could be given 4 weeks after the second dose of vaccine to protect the patient from MS. Now, India, I have not found any statement from the IAN or from the FDA. The Covaxin technology inactivated vaccine. The Covishield is a virus vector platform. Now, this is my guess that both these vaccines would be safe in the Indian patient with MS, though I suspect that Covaxin could be the better option for MS because it's clearly an inactivated vaccine. Formal studies and more data would probably test this hypothesis. Now, in real world in India, what is actually used? And we're absolutely like this elephant, as Dr. Singhal and other people have pointed out. Sometimes I feel I stand in the middle of the room and no one acknowledges me. And that is the drug rituximab. Please, exam-going students, people who are learning to use rituximab, please read this paper, Practical Neurology, November 2018. It's a complete literature on rituximab. It mentions everything about the science of rituximab, the art of the creation of rituximab, the art of using rituximab, and the dangers that you can encounter while using rituximab. This is from Anuj Jacobs and his group in Liverpool. And this is it. This is the B-cell antibodies, not US FDA cleared, but as the point was made, in India and in Sweden, it is used extensively. Indian publications for rituximab in MS and demyelinated disease are few, but the Swedes are very, very aggressive in pushing this drug. All of you for your attention, and I had a lot of help with the manipulation drugs from the various colleagues. Azad Irani has guided me a bit to some extent. Thank you so much.
Thank you very much, Ashok, and I really mean it. It was an absolutely fantastic exposition of the topic.
Yeah.
Open to discussion.
Yeah, Ashok.
Yeah.
I have sent you on WhatsApp.
Yeah.
Ashok,
MS
if you
data on AstraZeneca Oxford vaccine.
Yeah.
Just check your WhatsApp thing. Okay.
Yeah.
This I had sent to Miss Renuka Malekar, who's the secretary of the MSSI, All
Thank
India.
you. Yeah.
Okay, so there is data on the AstraZeneca.
Thanks. I'll add
It is
that. Yeah.
to be safe for patients of MS.
Yeah.
And many of my patients have been contacting me, and I have been sending this data to them.
Yeah.
All right. Ashok, can you stop sharing this slide deck? Yeah. We invite comments from Dr. Singhal.
No, actually, AstraZeneca vaccine, I think I've been advising my patients and nobody has come to any harm. Many of them have taken the vaccine. The question really would be to check the antibodies, how effective they are. So I think there is still remains to be done. At least if they've taken the vaccine 2 weeks after the second dose, they ought to do their antibodies and see, because I think there are some non-responders. So the question really is how effective these are. But they've been safe, in the sense that they haven't had any reaction. So I think, a statement by...
The question is, which disease-modifying drugs are there?
Exactly. That's very important to know. So whenever the patient asks me, I ask them, what drug you are on.
Correct.
And in fact, many of them are taking oral tablets, teriflunomide. Majority of them are teriflunomide. Some of them are I don't have any patient on fingolimod.
Okay.
The patients are
there any other?
Those who are on the rituximab, I think the vaccine may not produce the effect. It's better to avoid. At least nearing 6 months.
They talk about adjusting the dose, the timing of the dose of rituximab.
Quite right. I think when the next dose is due, before that you can take the vaccine.
We take the vaccination and then wait for a while and then take the
vaccine.
3 months.
Right. Absolutely. That is the practice that we follow.
And since it is 6 monthly, they can complete the vaccination schedule.
Sure.
Any other comments? Ashok, you wanted to say something?
No, that's it. I mean, the vaccination point was worrying it.
Yeah.
We have also been doing, to delay the use of the rituximab in these patients, because just now, COVID time, rituximab administration, patients can get very severe COVID. And therefore, it's good to delay the use of rituximab. Or in case they use it, they have to be completely isolated because of B cell depletion.
Yeah, true.
Yeah. So we go on to the next talk. Are there any other comments that anyone wants to make?
Because of the COVID times, should we use a lesser dose of rituximab, say a gram rather than 2 grams?
I think that you have to follow science. If the CD20 counts are high, then CD19, CD20 you have to go and give the right dose. Otherwise, no use.
Okay.
So let's go on to the next talk. Dr. Hiral is going to talk on progressive MS, and I have seen the presentation.
Yes, sir.
Yeah, the slides are visible here.
Okay, sir. Good morning, everyone. We now shall be discussing about progressive multiple sclerosis. So the outline of the talk is, first we'll briefly see the disease spectrum and some important definitions, then the pathogenesis, then the clinical diagnosis, and lastly management. So we are very familiar with these various subtypes of multiple sclerosis. The most common one we see is the relapsing remitting multiple sclerosis, that is about 80 to 85% of the patients. And then some of these patients will go into progressing to secondary progressive multiple sclerosis. And then the other subtypes of progressive MS are primary progressive multiple sclerosis and progressive relapsing multiple sclerosis. So these progressive forms of disease account for 10 to 15% of MS patients. They lead to basically gradual accumulation of disability. Now, when this occurs from the disease onset, it is known as primary progressive. And if it occurs after a period of relapsing disease, then we call it a secondary progressive MS. But these progressive forms are always diagnostically and therapeutically difficult cases. So this is to describe that these all forms basically belong to one spectrum of clinical and pathologic phenotypes. As we can see here, at one end of the spectrum, there are focal inflammatory lesions and leading to relapsing disease. And at the other end of spectrum, there is more of a neurodegeneration, more of a loss of brain volume and increasing disability, which leads to progressive disease. Now, some definitions, as we know that relapse can be either symptomatic or asymptomatic. Symptomatic meaning it will be distinct acute to subacute focal or multifocal CNS symptoms, and asymptomatic relapse meaning there will be subclinical activity on the MRI lesions. We can see new MRI lesions, but those will be without symptoms. And in both of these relapses, the pathological correlate is acute inflammatory demyelinating event with or without axonal injury. Now again, active versus inactive disease. So both of these relapses, symptomatic and asymptomatic, they are labeled as active diseases. Either patient will be having clinical symptomatic relapses or asymptomatic MRI activity, like increase in the contrast enhancing lesion or new T2 hyperintensities or enlarging T2 lesions which have previously existed. Both of these will label as active diseases. Whereas when there is no evidence of disease activity for at least 1 year period, then we call it inactive disease. Now, clinical recovery is defined as maximum improvement attained after the peak deficit related to a relapse. And this improvement is maximum within the first 3 months, and it rarely continues beyond the 6 months after relapse. And during this period in which the recovery takes place is known as remission phase. And in this phase, there occurs some level of restoration of myelin and axonal integrity. They can be associated with recovery in MRI lesions as well, like resolution of enhancement or restoration of the diffusion characteristic or either shrinkage in the size of MS lesions. Now, important definitions here are progression and pseudo-progression. So what do we call a progression? Progression is insidious and irreversible worsening of neurological function due to multiple sclerosis over years. And the most common pathological correlate of this progression is progressive axonal injury or loss. Whereas the pseudo-progression is insidious accretion of disability due to deconditioning because of the long-term reduced mobility, because of the MS, either due to degenerative joint diseases or because of the concomitant medical illnesses associated with progressive fatigue or other causes of myelopathy or other concomitant neurodegenerative diseases. This all can also lead to progression, but in that we'll call it a pseudo-progression. Also, it is important to differentiate progression from disability worsening. Now, disability worsening can be due to either because of the partially recovered relapses from previous relapsing variety of multiple sclerosis, or either progressive MS or again non-MS related factors. The difference here is that in disability worsening, it's not necessarily they will not be having necessarily underlying pathomechanisms which underlie the progression. So the underlying pathomechanism will differ in the disability worsening. So which are these underlying pathomechanisms? So the pathogenesis of progressive MS, inflammation of course, but inflammation here in progressive MS is qualitatively different from that in the relapsing MS. Inflammation here will be more compartmentalized with more or less intact blood-brain barrier. And there will be formation of meningeal lymphoid aggregates, which will be populated by T cells and B cells. Most important pathology is axonal degeneration, which will lead to loss of trophic support to the neurons, and this degeneration can happen anterograde or retrogradely as well. Another important thing is microglial activation, which occurs surrounding the chronic active lesions, and that leads to oxidative stress and promotes the immune-mediated inflammation and injury. Also, there occurs some mitochondrial dysfunction, oxidative stress, and glutamate excitotoxicity also plays a role in the pathomechanisms. So when do we call secondary progressive multiple sclerosis? So when there is worsening of EDSS score occurring in absence of relapse, and this worsening of score should be confirmed after 3 months, meaning that this worsening should be sustained over 3 months. And this is in context of an overall EDSS score of 4 or more and a pyramidal score contributing 2 or more in this. Now, median time to reach this SPMS stage is 10 to 20 years, and this is somewhat rapid in male sex, in patients with predominant motor deficits, and the patients presenting at later age of onset. The 2017 revised McDonald diagnostic criteria for progressive MS state that 1 year of disability and progression, either retrospectively or prospectively determined, independent of relapses, when it is associated with at least 2 of these 3, which are first, 1 or more T2 lesions in characteristic brain MRI, in characteristic regions on brain MRI, or 2 or more spinal cord MRI lesions, or the presence of CSF oligoclonal bands. When 2 of these 3 are present, along with 1 year of disability and progression without relapses, we call it a progressive MS. The clinical phenotype of progressive MS, it slightly differs from the relapsing variety of MS. These patients will usually have a later age of onset. They'll mainly present with the motor features. The most common presentation here is progressive myelopathy, present in 80 to 85% of patients. Another important presentation is progressive cerebellar ataxia, and also some will have visual, brainstem, or cognitive symptoms. Importantly, prognosis is worse in progressive MS because it will lead to rapid accrual of disability and early requirement of ambulatory assistance. So these are main differentiating features of RRMS, primary progressive MS, and secondary progressive MS. As we know, RRMS will be having predominantly relapses, whereas primary progressive will have progressive accrual of disability without relapses, and SPMS is progressive accrual of disability after an initial relapsing course, and then it may or may not have concomitant relapsing. The typical clinical syndromes of RRMS are, as discussed earlier, optic neuritis or partial transverse myelitis or brainstem syndrome. Whereas in PPMS and SPMS, typical clinical syndrome are those of progressive myelopathy or progressive cerebellar syndrome. Also, the age and gender ratios differ in amongst these variety. RRMS and SPMS, these are both more common in females. 3:2 to 3:1 ratio. Whereas PPMS, there are not much gender differences. They are equally present in male and females, and the age of onset is distinctly different. It is more than 40 years of patient will be having primary progressive MS will be having onset at after 40 years of mainly. The MRI differentiating features in brain MRI, in RRMS there will be low initial lesion volume, and that keeps on increasing every time when they have relapses. Whereas in PPMS, the brain lesion volume is overall low compared to RRMS, but there will be greater spinal cord lesion volume compared to RRMS. And also the cortical lesions are higher in number and volume in the PPMS variety. Also, new lesions and enhancing lesions will be frequent in RRMS only. They will be rarely present in PPMS or SPMS. So the investigation for suspected PPMS should be more rigorous than that of RRMS, because many of other conditions can clinically mimic the PPMS. Like for example, degenerative causes and motor neuron disease or structural myelopathy, or hereditary causes like spinocerebellar ataxias, leukodystrophies, metabolic, importantly, vitamin B12 and copper deficiencies. Infective causes, obviously, we have to screen all of these patients for infections like HIV, syphilis, and also for vasculitis. Now, how do we measure this disease progression? So we are familiar with this score, Expanded Disability Status Scale, EDSS, which ranges from 0, which is normal neurological examination, to 10, that is death due to MS. And from 0 to 10, the major milestones are achieved at, one is at 4, where there occurs increasing limitation in the daily physical activities. At 6, the patient will require unilateral gait assistance. At 6.5, there will be bilateral gait assistance. At 7 or 8, patient will be wheelchair bound, and then at 9 score, patient will be bedridden. So to label it as progression, there should be worsening of EDSS score of at least 1 point, and that should be sustained over 3 to 6 months. So worsening sustained over 3 to 6 months of at least 1 point, then we call it a progression. But there also exists some difference of opinion. Some believe that we should believe when it is sustained over 12 or 24 months to have a better accuracy of assessment. And also some believe that when the overall EDSS score is more than 5.5 or 6, even we should allow even 0.5 increase in the score to label it as progression. Another important score for measurement of disability is Multiple Sclerosis Functional Composite, MSFC. Now, it is a quantitative composite of neurological performance across the several spheres. Mainly four neurological spheres are included here. For lower extremity function, the test is timed 25-foot walk test. For upper limb function, there is 9 hall peg test. For cognition, there is symbol digits modality test. And for vision, there is letter acuity test. And for each of these tests, there are predefined thresholds of clinical changes above which will label it as progression. So when there is 20% change in the time 25-foot walk test or 20% change in the 9 hall peg test, we call it a progression. And also another score is EDSS plus, which combines EDSS plus some of the composites of this MSFC score, and it is thought to be better and reliable score. But actually in clinical practice, what matters most is the objective worsening on neurological examination or simply by the patient reporting of the sustained worsening. So the patient reported outcomes are the most important measure of progression. Now the imaging aspects of progressive MS. So this is a common classical MS picture which we are used to see, that there are T2 and flare hyperintensities, and the characteristic brain regions are periventricular, perpendicular to the corpus callosum, in the spinal cord, in the brainstem. This is the common picture of multiple sclerosis what we get. But in the progressive MS, the MRI findings differ to some extent. Here, the clinical disability is not very well explained by MRI lesions. So this graph very nicely shows the radiological evolution of multiple sclerosis across the spectrum. So to begin with, radiologically and clinically isolated syndrome and RRMS, these arrows are showing inflammatory lesions, and hence the contrast enhancing lesions. So there are a lot of inflammatory and enhancing lesions in the relapsing varieties. But at the progressive end of MS, in the SPMS and PPMS, the white matter damage, the gray matter damage, and the cord damage goes on increasing. Also, the number of T2 lesions increase to till some point, and then it plateaus. So there is not much increase in the number of T2 lesion, but the gray matter, white matter damage goes on increasing, and also there is greater loss of brain volume and atrophy, which occurs more at the progressive end of the spectrum. So there is diffuse tissue injury in the normal appearing white matter. Gray matter damage also occurs, which is in form of cortical lesions and diffuse changes, and these are the predictors of disability. As I discussed earlier, progressive MS will have fewer T2 brain lesions, but there will be greater load of cortical lesions. Low inflammatory infiltrates because the blood-brain barrier remains relatively intact, and hence less contrast-enhancing lesions. There is also greater loss of brain volume, and the pattern of volume loss also differs. In relapsing variety, it occurs mainly in the periventricular characteristic regions of the brain, whereas in progressive MS, it is more in the cortical regions and also in the deep gray matter nuclei as well, like thalamus, hypothalamus, etc. So to pick up these kind of abnormalities, we need advanced MRI techniques which target myelin, microglia, iron, or axon. in which this with this advanced techniques only we can pick up this occult injury in the normal appearing white matter and gray matter. So some of these techniques are magnetization transfer imaging, diffusion tensor imaging, and MR spectroscopy. So this is one example of the double inversion recovery. So the second row is showing the routine flare sequence. Here it shows scattered flare hyperintensities in the subcortical white matter and some in the juxtacortical region as well. But as you can see, these are not very distinctly defined, not very much, we cannot appreciate this very much. But here on the double inversion recovery, what it does is that in addition to the CSF, it suppresses the white matter signal as well. So here we can appreciate these juxtacortical lesions much better than the flare sequence. Same here, like this is T2 hyperintensity, this is a flare hyperintensity, and much better appreciated on the double inversion recovery. Now, lastly, the management strategies. So mainly two strategies, immunomodulation and neuroprotection. For immunomodulation, we have limited choice of drugs for progressive MS. Ocrelizumab, which acts on the CD20 receptor on B cell, and rituximab as well. Mitoxantrone, which acts on both. It suppresses both B cell and T cell. And siponimod, which is a more selective sphingosine 1-phosphate receptor modulator. Neuroprotection, various neuroprotective agents are promoted, but none of them have a very significant benefit. Ibudilast is a phosphodiesterase 4 enzyme inhibitor. Simvastatin has also been shown to have modest reduction in the EDSS score in trials. Then the lipoic acid and high-dose biotin therapy also helps in remyelination and neuroprotection. So as for the disease-modifying therapies, the early trials with azathioprine, mycophenolate mofetil, cyclosporine, and cyclophosphamide have largely been negative. Even the natalizumab and fingolimab have failed in progressive MS. The siponimod is approved for secondary progressive MS in 2019, and it has shown 21% reduction in 3-month confirmed disability progression. Mitoxantrone, as mentioned earlier in the discussion, it is to be used when the patient is rapidly worsening or is very much disabled in case of secondary progressive MS. Since it is a cheaper alternative in our setup, we can use it when the patient is having experiencing rapid relapses, but the side effects are limitation because it causes myelosuppression and cardiotoxicity, which limits its use in the older population. These are various recent trials of drugs for progressive MS: glitazone acetate, rituximab, fingolimod, and ocrelizumab. The important ones, rituximab and ocrelizumab, will discuss. So firstly, why B-cell therapies? So why B-cell? Because it has been shown that in progressive MS, the inflammation, as I said earlier, is qualitatively different from the relapsing variety. And here the meningeal lymphoid aggregates, which propagates the chronic active lesion and chronic disease activity, they are densely populated by B cells. And hence the B cell are prime target of therapy here. On B cell, there is a marker called CD20, which is present in the pre-B cell, mature cell, and memory B cell, but importantly not on the early precursor B cell. So hence, these precursor B cells are spared and they can always reconstitute the immunity once the drug is given. This is a complex diagram just to show how rituximab acts. These are the CD20 receptors on the B cell, the blue lines, and the red ones are the rituximab, which acts on the CD20 receptor by various mechanisms. It leads to B cell suppression. One of these is antibody-mediated cytotoxicity. Another is complement-mediated cytotoxicity, and also it promotes the apoptosis. So among the B-cell therapy, important one is rituximab, and the important trial is Olympus trial done in 2009, in which they included 439 patients of primary progressive MS, and 1 gram of rituximab was given every 24 weeks, and such 4 courses were given through 96 weeks. And the primary endpoint of the study was time to confirmed disease progression. But they did not find any significant difference in time to this disease progression in the patient receiving rituximab, though there was some less increase in the T2 brain lesions in patient receiving rituximab. But when they did the subgroup analysis, the time to confirm disease progression was significantly delayed in younger patients, that is less than 51 years of patient, and those with the enhancing lesion. So in this population of patient, rituximab can be very useful in progressive MS. And as sir mentioned earlier, because of our larger experience, we are still using it as off-label. The ocrelizumab trial for ocrelizumab was done in 2016. There is Oroterio trial in which they included 732 patients, and the patients age group of patients included was 18 to 55, and the baseline EDSS score of patients included were 3 to 6.5, and they all had presence of increased IgG index or OCBs. They all were given IV infusion of 600 milligram ocrelizumab every 24 weeks for at least 120 weeks. The primary endpoints of study were confirmed disease progression at 12 weeks, and the secondary endpoint was disease progression at 24 weeks. Also, they utilized some of the tests of time, like timed 25-foot walk test and MRI endpoints for the outcome. And this study was published in the NEGM journal in 2017. And the results were that ocrelizumab, patients who were given ocrelizumab, they showed significant benefit. The confirmed disease progression at 12 weeks was 32% in ocrelizumab versus 39% in placebo, which was clinically significant. Also, secondary and clinical endpoints was also achieved. Disease or disability progression at 24 weeks was significantly less in ocrelizumab compared to placebo. For the MRI endpoints, they included the total volume of T2 brain lesions. So in patients receiving ocrelizumab, as you can see here, the total volume of T2 brain lesions were quite low than the placebo. And also the decline in brain volume, that is atrophy, was also somewhat low in patients receiving ocrelizumab. The next important point in therapy is the patients who earlier had relapsing variety and they went on developing progressive MS. So whether we should continue or discontinue the disease modifying drug. So it's still a matter of debate. Some believe that there is some risk of disease reactivation when we discontinue this disease modifying therapy. But then another line of thought is that those patients who are 55 years or older and who have not had any evidence of new relapses for at least 5 years, or brain MRI lesions for at least 3 years, while on this disease modifying therapy. So when they do not have relapses, active relapses, the chance of having new relapse is no higher. So we can very well discontinue this DMTs, but the larger trial for this is still ongoing, and the results will be coming in February 2020, in which they will be comparing the number of patients who will have the new disease activity in two groups. In one group, they will discontinue the therapy, and the other while on continuing the therapy. Then lastly, neuroprotective agents, simvastatin, ibudilast, and high-dose biotin therapy. And also, one study called MS SMART study had compared riluzole, amiloride, and fluoxetine, but the results were negative. So for all we know, there are still many challenges to the PPMS therapeutic trials, which are the patients are usually older with some comorbidities, to which limits the use of aggressive drugs. They also complicate trial design. They affect the baseline EDSS scores, and because they do not experience much benefit or very slow and modest benefits, so there are high dropout rates as well. So currently we are in definite need of novel therapeutics, and also we need the means with which we can better monitor the progression. Thank you.
Thank you, Hiral. I think that was comprehensive. I think just one or two thoughts on the progressive MS. I mean, in a sense, every patient of MS is progressive. So I think saying that it's progressive MS, I mean, in a way, it's a concept based on progressing disability. But MS is a disease by its very nature, which progresses to a lesser or greater extent. And we have sort of divided the ways in which it progresses. I think RRMS and SPMS are probably in the same spectrum, where initially, clinically, the disability goes away, and subsequently it stops going away. And at-rest disability accrues. So those two stages of the spectrum are easy to understand. I think they are both progressive. PPMS is a slightly different cup of tea where patient has never had any ups and downs. And that's a diagnosis which makes you sit up and say, oh, am I okay? Or is there a differential diagnosis here? And you probably go through the differential diagnostic process more intensely when you see a primary progressive multiple sclerosis. And as we have seen in her presentation, as the duration goes on and the disability starts progressing without that much of radiological correlation, then the drugs acting, the chances become less and less. So shall we open it for discussion? I think PPMS is always a worry. You know? Is there another diagnosis?
Satish, if what you say
Yes.
is right, then this entity of NEDA, no evidence of disease activity, would not have been there.
That's the aim, sir.
But there are people who have achieved NEDA.
Yes, thanks to drugs, we have changed in those people the
So
disease course.
the newer drugs have changed the overall, even understanding of the disease and have changed the overall outlook of the disease also.
Yes.
So there is an entity which is called as no evidence of disease activity. If there's
Yes.
no evidence of disease activity, means that it is not progressive.
But it's
Whether
based
it's
on a
induced
presumption
by
that it is progressive.
whether it's induced by drugs or whether it is a natural history of the disease process in that individual patient.
Yes.
Now, to make things more complex also, I have one patient, I won't mention names. This lady has been seen by Dr. Singhal also about 2 years before I saw the patient. And I compared Dr. Singhal's notes and then compared my notes. And I said, this lady has primary non-progressive MS if there is such an entity. Because
So burnt out. What you mean is a burnt out disease.
my findings after 2 years were exactly similar to Dr. Singhal's findings 2 years before. And that was the only episode that she had. And she remained with that residual stable deficit.
Yes.
But she is the only case that I have seen which I can say is primary non-progressive MS.
As good as the
If there
CIS.
is, sorry?
As good as the CIS almost.
Maybe one CIS, but
Chemically
with what's cerebellar signs and spastic residual.
So, sir, did you continue her disease modifying therapy or did you stop it?
She was not on any disease modifying therapy. This was long ago. And
so it's a
anyway,
natural history.
I'll tell you the further follow up on her. When ocrelizumab was on a research basis, she went to the United States and she got it with informed consent. Ocrelizumab. 3 years after receiving ocrelizumab, I saw her again and she was practically the same. So I told her, please do not continue with ocrelizumab. Anyway, she had taken one dose. She was supposed to take the dose the next year, but she didn't go back. So, this is a peculiar disease, which has started as a demyelination, then has gone to inflammation, and then gone to neurodegeneration. It has really straddled all the pathologies that we really know of, you know, as we understand the disease more and more. Okay.
Yes.
Sarosh, it is like this that, of course, TRAP, from the Cleveland has shown axonal degeneration early on.
Right.
Warning that we should start using the DMTs early. But we have patients, who have not taken any drug for nearly 12 years and 14 years and haven't had anything further. They might have had 1 or 2 relapses, but they haven't worsened. They're still active. So I have a feeling that there are active cases and inactive cases.
Correct. If there were no inactive cases, they would not have coined this term of no evidence of disease activity.
Correct.
Yes.
Yes, Satish.
No, sir. What I was going to say that if we sort of believe that the hypothesis is that every MS is progressive to a lesser or greater extent, we are just saying that some stop at some point and others go on. Some stop naturally, others stop with medicine. But it's in a way a process that will go on to whatever is destined for that particular individual. So is it okay to say progressive MS? And I mean, that's just a description. Also, the word is very deceptive. It's not progressing, it's actually regressing in terms of abilities.
No. Progression of the disease process.
The regression of the abilities, which is what we are.
Which induces a regression of the patient.
So actually, the progress is a word that I think we have coined to mask that we're not able to say that is actually regression.
I don't think so. I think the masters in the past have studied the disease, and I think it is the clinical history that is progressive.
Sir, so many patients, I'm sorry, I'm just pursuing on this point. So many patients, when you tell them the disease has progressed, they consider it as success because we have termed it like that. They have to be explained that, look, this is the progress of the problem and is increase of the problem. So I think that it's a sort of softened word or a word that we are used to using, but
they don't
it actually reverse.
I think it scares them out when you say the disease has progressed.
Oh, yeah,
to avoid that, we use this term. Sir, Dr. Singhal, sir, one question. How often have you seen RRMS not going into SPMS?
The follow-up is not so good, Satish, to be able to answer.
But a general impression?
The general impression is that there are many patients who remain RRMS and not gone into progression at all.
Who remain RRMS.
Yes. And in fact, there are many patients, who said that, look, I had first seen you in, 2002, and now I've got just a minor little problem, I want to see. I haven't had many relapses at all. They might have had 1 or 2 minor relapses, nothing at all. And they're quite active. It's been a follow-up now of 25, 30 years. So there are some patients. And in fact, earlier on, in some of the CIS patients, we have not started the drug. English people would not start, and Americans will always start. There's also another difference, between Indian and the Western society. In the Western society, the person has to live on his own.
Yes.
They got to do everything, Even though there's a handicap, they may still have to take a driving license, go to the mall, purchase the thing. So by living is very much different there. Unlike in India. Of course, now things are changing even in India in the last 30 years.
Very frankly, I would agree with you. Okay, there are many patients who remain as RRMS, and many of them do not have a relapse for the next 2 years, 5 years, etc. And those are the patients that you normally do follow up. So if we
somehow I had felt
follow up, you may find many.
These are all anecdotes.
I agree.
Many of them have.
Follow-ups are never perfect. I mean, that is
Yeah.
the bane of Indian
Yeah, I mean,
neurology.
we don't do EDS. We don't do EDSS. Yeah.
We do EDSs all the time, no? But we don't do 7-foot walk. I mean, 25-foot walk or 9-hole peg test. You know?
And like you said, the registry had just begun. We do not really know the good long-term follow-ups.
No, not at all. And unfortunately, you know, there's no institutional support. You know, for instance, I've got 1541 patients, you know, recorded, but to follow them up and give them a call is tough. You know.
Yes.
Patients are, you know, quite supportive. They give them a call. We got telephone numbers now, but you know, you just can't sit and keep doing that. You know, it's very difficult.
And any comment on PPMS, sir?
Well,
It's a slightly
PPMS
it's a slightly disturbing diagnosis to
very
make because you're
well,
always
I think,
worried.
well, I think there are cases of PPMS. You know, I've got about you know a dozen of them. You know, I think they try all sorts of treatments. One of the patients went to Bangkok, where you know I think he felt a bit better and came back. So I don't know whether it was just the physiotherapy and various things. So not much difference on objective examination. Another patient went to Moscow and has taken the treatment. In fact, he made me talk to the Moscow doctor when he was there. And he had the total ablation followed by stem cell therapy. And he thinks that he is somewhat better.
Okay.
Placebo effect.
It may not be placebo, it may be true. He's a Kashmiri patient staying in Bombay. And I think I've seen him, and his wife also is happy that he's slightly better. Okay. Comment of the wife would be important. And he had also not promised recovery. For the EDS about 5, it is probably around 4 now.
So are there any other comments, questions before we go on to the last one?
Hello?
Ashok, any comment?
Yeah.
Okay. So we move on to the last
How
presentation,
much is
which
the
is
money to be sent?
NMO spectrum disorder and other non-MS CNS inflammatory disorders. Arjun Shah is going to do along with Professor Katra. Arjun, you want to put your slides up?
Sure, sir. Are the slides visible and am I audible?
Yes, visible and audible. Yeah.
Good afternoon, everyone. Today I'll be presenting on neuromyelitis optica spectrum disorders and some other non-MS central nervous system inflammatory diseases under the aegis of Professor Katrak. So let's get right into it with NMO-SD. So it all started in France with the thesis of Fernand Galt under Eugene Devic, and there were some more contributions from Turkey by Peppo Akiote. Finally, there was an entity called Asian Oculospinal MS. And finally, a century later, here we are with neuromyelitis optica spectrum disorders. So for the epidemiology we've gone through some Indian data. So the article we found was from Urban Mangalore, which says that NMO has a prevalence of about 2.6 per 1 lakh population, as opposed to MS, which is reportedly more common at 8.3 per 1 lakh population. Although at least in our JJ patients, it seems that NMO far outnumbers MS, although this data doesn't say that. It's believed that NMO is almost 20% of all demyelinating diseases in India. The mean age of onset is usually early 30s to mid 40s, and the median time to first relapse without treatment is about 1 year. So the clinical manifestations of neuromyelitis optica spectrum disorders, there are 3 cardinal manifestations, which is myelitis, optic neuritis, and brainstem syndromes, the most popular of them being the area postrema syndrome. Typically, these diseases have a relapsing cause and a secondary progressive course, though described is exceedingly rare. So the myelitis of NMO, it has the usual suspects, the numbness, weakness, finger disturbances, and Lermit signs. A few caveats in this. Firstly, it reaches the nadir within a few days to a few weeks. So if you have a patient whose myelitis is progressing for more than a month, it's a red flag sign and we should think of something other than NMO. And unlike multiple sclerosis, the myelitis of NMO is extremely disabling. Another characteristic feature that is seen in half the patients and is very rare in MS are these responsive tonic spasms that last less than a minute, and they are usually triggered by movement. And these can actually respond to carbamazepine, so it's important to look out for them. The optic neuritis of NMOSD is more severe. It's usually bilateral and it has poor recovery. The area postrema syndrome usually presents with intractable nausea and vomiting. There might be hiccups along with them as well. And it's important to know that these can occur in isolation without any other neurological signs. So very often we might have these patients referred from internal medicine or even gastroenterology. Coexisting autoimmunity, about 40% of patients with aquaporin 4 positivity are known to have some coexisting autoimmune disorders. The most common being lupus erythematosus, Sjogren's syndrome, and antiphospholipid antibody syndrome. And it's important to know that if any other patients with these diseases start showing cardinal features of NMOSD, that is myelitis, optic neuritis, or a brainstem syndrome, then we should test for aquaporin 4, because we need to differentiate whether these new neurological symptoms are just neurological manifestation of this other autoimmune disease, or there is a coexisting disease in the form of NMOSD, which might require some different treatment. So as expected, NMOSD with APLA leads to more abortions and more venous thrombosis. And it's even seen that myasthenia occurs more frequently in patients with NMOSD.
Arjun, at
So
this
this is the
stage,
imaging of
may I
the...
say something? Arjun,
Yes, sir.
at this stage,
Yes,
may
sir.
I say something on your previous slide? On your previous slide, yeah. I think for the postgraduate students, it's very important to understand that about 25 to 40% of NMO spectrum disorders may have other antibodies and other diseases, autoimmune disorders, particularly SLE. And the rheumatologist must have a very low index for doing aquaporin 4 antibodies. For example, if there is unexplained vomiting in a case of SLE, I think the rheumatologist must
इस बीच में कुछ करना है
sorry,
कपड़े तो बदलो
Dr. Singh, kindly mute his mic. Or if there is an unexplained optic neuritis in a case of SLE, I think aquaporin 4 antibodies should be done. So that is the importance of this sort of things. Okay, when there is in such disorders, autoimmune disorders, when there is an unexplained finding, please think in terms of aquaporin 4 antibodies. Proceed, Arjun.
So the optic neuritis of NMO is, as we've discussed, usually bilateral, and it has a propensity to afflict the posterior optic pathway, including the optic chiasm, and characteristically involves more than half the length of the optic nerve, as shown in these MRI figures. Brain lesions, it's important to know that about 10 or 20% of these patients might have MS-like lesions, but usually there are some characteristic lesions seen in NMOSD. So they are usually circumventricular, adjacent to the third or fourth ventricle. We see hyperintensities in the dorsal medulla and area postrema, as shown in figure C. Sometimes they can present with an ADEM like MRI, or even a press like MRI, which can cause diagnostic confusion, especially if you have a young girl with a narcolepsy like syndrome or altered sensorium. We can have lesions in the internal capsule, as shown in the MRI labeled E, and there can be corpus callosum lesions as well. And another characteristic lesion is a pencil thin ependymal enhancement, as shown in figure F, which might be easy to miss. Spinal cord MRI in NMOSD is usually LETM, that is longitudinally extensive transverse myelitis, affecting at least 3 or more contiguous segments of the spinal cord. The lesions are syringe-like, and they are usually central lesions. And if it is a relapsing cause, there might be long segment cord atrophy. It's important to know that 15% of children with MS might present with longitudinally extensive transverse myelitis. At the same time, 15% of NMO patients might have short lesions on their MRI. So none of these are the rule. The CSF findings in NMOSD is extremely variable. There's usually a lymphocytic predominance in the cells, but there can be neutrophilic or eosinophilic predominance as well, which helps us differentiate between MS and MOG antibody disease, as we'll discuss later. Another important thing to note is 20 to 30% might have oligoclonal bands, as opposed to MS patients in which 80% have oligoclonal bands. So that's a substantial number. The aquaporin for IgG testing that we do, a few important points in this. Firstly, that blood is more sensitive. So we should not send CSF samples. We should test the serum because it's more sensitive. And the cell-based assay, that is the immunofluorescence assay, is currently the gold standard in serology with an 80% sensitivity and 99% specificity. So this is a report of one of our patients. The standard labs do this immunofluorescence only. The older method, the ELISA, has a very, very high rate of false positives. So it's best avoided. The diagnostic criteria, the International Panel for NMO Diagnosis, or Wingerchuk's criteria. So they've basically divided all the patients into two broad categories: those that are aquaporin for IgG positive, and those that are aquaporin for negative. In those patients who have an aquaporin for positivity, these patients need to have at least one core clinical criteria, and we need to exclude all other alternatives. So what are these core clinical criteria? There's 6 of them. The first is optic neuritis, then myelitis, an area postrema syndrome, any other acute brainstem syndrome, narcolepsy or an acute diencephalic syndrome, that is drowsiness, sleepiness, altered sensorium, behavioral changes. And these should be associated with MRI lesions, or they can be a symptomatic cerebral syndrome with corresponding lesions on imaging. Now, on the other hand, if you have a patient who has aquaporin negative, an aquaporin for negative report, or as an unknown status, which happens quite commonly in our setup, where either patients cannot afford the test, or the test takes a week or 2 to come from the labs, and the patient has an acute problem that requires rescue therapy. In these patients, they need to have at least 2 core clinical characteristics, and then the following 3 should also be fulfilled with that. That is, at least one of these clinical characteristics must be either optic neuritis, transverse myelitis, which is longitudinally extensive, or an area postrema syndrome. That is the 3 cardinal features. There must be dissemination in space. That is, one lesion is not sufficient to explain all of these clinical features. And we need to see the MRI and make sure that additional MRI criteria are also confirmed. Obviously, excluding other alternative diagnoses is of paramount importance in such a situation. So what are these additional MRI findings? If the patient has acute optic neuritis, then the MRI must either have normal findings or only non-specific white matter lesions, or they must have the characteristic enhancing lesions which affect more than half the length of the optic nerve, predominantly posteriorly, possibly involving the chiasm. If the patient has acute myelitis, then the MRI should show a longitudinally extensive transverse myelitis. And if the patient presents with an area postrema syndrome, it must be corroborated with dorsal medullary or area postrema lesions on the MRI. If the patient has an acute brainstem syndrome, then they must have periependymal brainstem lesions along with it. So just the clinical feature isn't enough in these situations.
Arjun, one more thing.
Yes, sir.
Previous slide again. The best way to remember about the MRI findings of optic neuritis in NMO is to remember that it is a posteriorly, longitudinally extensive enhancement of the optic nerves. Just as you have longitudinally extensive transverse myelitis, the optic neuritis is also posterior longitudinally extensive. That is the best way to remember the optic neuritis findings of NMO spectrum disorders. Proceed, Arjun.
So almost 20 to 25% of patients are labeled seronegative NMOSD. And what's seen nowadays is if we test all of these for MOG antibodies, 25% of these will be MOG positive. So perhaps a lot of the patients historically who were treated as seronegative NMOSD might actually have MOG antibody disease. However, there is no difference in treatment between aquaporin 4 negative and positive patients in clinical practice. The difference is only in trials. So the treatment, acute treatment, high dose steroids is usually the mainstay of therapy, although it must be noted that this is such an extensive disease radiologically and clinically that it's usually not enough. So plasma exchange is usually recommended, and it's also recommended that we have a low threshold for plasma exchange. So in fact, if we suspect a patient to have NMOSD in the fit criteria, it's better to initiate plasma exchange because it's a very extensive disease. IVIG is used occasionally. However, it's not recommended, and this is partly because most of the trials that were done with IVIG were after the acute stage. So there is anecdotal evidence that IVIG also might be useful in the acute stage. However, the standard of care is plasma exchange with a low threshold for it. Maintenance therapy, again, there haven't been too many good studies and randomized controlled trials, but based on observational studies, rituximab is the most popular option and probably the best option that we have right now, followed by mycophenolate, followed by azathioprine. Methotrexate, mitoxantrone, cyclophosphamide are used occasionally, but they are not as effective as the previous three. An important point is it's very important to differentiate and rule out multiple sclerosis in these patients, and vice versa, because giving MS medications in a patient with NMOSD might actually worsen the disease. Some new trends, there are some new medicines that are being tried in phase 3 trials. So the first is eculizumab, which is a C5 complement inhibitor. It inhibits the membrane attack complex, and it's in phase 3 trials right now, and they've shown almost 94% reduction in further remissions. One thing I'd like to add here is all of these trials are placebo controlled trials, so they're extremely unethical because a group of these patients aren't getting any medicines at all. The second therapy that is being tried right now is a drug called inebilizumab, which is almost sort of mocking us because of our inability to pronounce these difficult names. So inebilizumab. This is also an interleukin 6 receptor antibody. It inhibits the plasmablasts, that is the CD19, CD20. So it's very, very similar to rituximab in terms of mechanism of action. Again, an RCT is underway. Again, it's a placebo-controlled trial, which is quite unethical. The next anti-interleukin 6 medicine that is in trials is satralizumab, and this has only, so the first two medicines have been shown to show some efficacy in aquaporin 4 negative patients as well, although most of the patients are aquaporin 4 positive, but satralizumab only shows efficacy in aquaporin 4 positive patients, and it can cause hypercholesterolemia. Tocilizumab, which is used for RA, is another thing that is being studied. An interesting study was done using cetrizine because CSF shows eosinophils and there is some role of some eosinophils in the pathology. However, there isn't, the trial that was done was very small and it's just a level 4 recommendation, and cetrizine has its own side effects and drowsiness, so not recommended. Moving on to MOG antibody disease, or as the kids nowadays call it, MOGAD. The clinical features of this disease are similar, but a few important points are they present with prodromal features like fever, rhinorrhea, malaise, cough. So they're very often confused with viral or post-viral infection. So we have many of patients who come with demyelination and they have some sort of fever in the past, and then we ostensibly label them as some sort of infectious, post-infectious demyelinating disorder. Most common clinical feature in this is also optic neuritis. It does have transverse myelitis, which is longitudinally extensive, and brainstem lesions. The demographics here vary a bit. Males and females are equally affected by this, and this presents at a slightly younger age compared to NMOSD, which is early 30s to mid 40s. This disease is more severe than MS, but has a better recovery than NMOSD. So it's somewhere in the middle when it comes to clinical severity. And 86% of these patients will have optic neuritis, by far the most common clinical feature, and half of these patients will have both eyes affected by optic neuritis. A few interesting statistics: 15% of patients who come with recurrent optic neuritis will end up being MOG positive if tested, and in all the patients with longitudinally extensive transverse myelitis, about 2% of them are represented by MOG antibody disease. And usually they present with bowel, bladder, and erectile dysfunction because, as we'll see, the myelitis is usually more lower down in the lumbosacral region as compared to NMOSD. The cause of the disease, it's usually a monophasic disease, but there have been reports of relapsing patients as well. And the MOG IgG titers are a little interesting. High titers might suggest a higher risk of relapse as opposed to other disease where they are just used to either diagnose a disease or not. So there is a role of repeating MOG antibody titers every 6 months to 12 months. A secondary progressive clinical syndrome has not been reported so far. So some MRI characteristics, again, more than half the optic nerve length is usually involved, and this extends into the surrounding fat as well. And this is usually anterior without chiasmal involvement. So more than half, but anterior as opposed to NMOSD, which is posterior predominant. Brain lesions, usually we see these multifocal white matter hyperintensities, which might affect the deep gray matter, and they are very ADEM-like, again, which along with the prodromal fever and malaise and this sort of MRI finding, again, it's very difficult to distinguish a viral or post-viral syndrome from this. What's important is the typical MS-like lesions are not seen in MOG, where they might be seen in 10 to 20% of NMOSD patients. Spinal cord lesions, again, longitudinally extensive transverse myelitis is common. 60 to 70% will have this, and it's usually in the lumbosacral region. NMOSD, it's a little more higher, the cervical region. They can be long and short, either separately or together as well. And usually on axial images, this causes a central affliction, and there is a classical axial H sign that has been described. It is mainly only in the gray matter. In aquaporin 4, both the gray matter and the white matter are involved. So here are some lesions, the transverse lesion showing this characteristic H type of hyperintensity, which is canonical of MOG antibody disease. So a few remarks on the serology in the testing of MOG antibody. It's very important to know that this is a very new disease. So we don't know much about the serology and its implications. And there is clearly a high false positive rate. So it must be stressed that we should not test this in all. So it should not be like a panel that any patient who has some sort of autoimmune disease, we send MOG as well, because there are high false positives and we end up with results we don't have any answers for. So we need to describe well thought of indications. So any patient who has a classical phenotype, optic neuritis, LETM, maybe a prodrome of fever, the imaging is suggestive of MOG and anterior predominant optic neuritis and is not fitting into MS or any of the other diseases. For these patients, we should test MOG antibodies. Once again, not CSF, but blood sample should be sent. So there's no need to make the patient endure a CSF unless absolutely required. Once again, cell-based immunofluorescence is recommended, and that is done in most standardized labs over here. And it might be, if it is persistent, it might predict relapses. So unlike other antibodies, it is recommended that every 6 months or maybe 12 months, we keep repeating this MOG titers. The treatment in the acute stage is very similar to NMOSD, that is corticosteroids, plasma exchange, and the difference is IVIG has been studied, especially in children, and it's as useful as plasma exchange. The maintenance therapy again is very similar to NMOSD, with rituximab being the favored agent, followed by mycophenolate and azathioprine, and also steroids, prednisolone for maintenance. In the interest of time, I'll just quickly go through the other inflammatory CNS disorders, and I'd recommend, sir recommends we go through this article which covers all of them in detail. I'll just name all of them. So we have an entity called autoimmune glial fibrillary acidic protein astropathy. We can have the paraneoplastic diseases like CRMP5 or GABA-A. We have other autoimmune diseases like neurobehcets or neurosarcoidosis. And we have chronic lymphocytic inflammation with pontine perivascular enhancement, which is responsive to steroids, stylized clippers. And we have some vascular mimics like Suzak syndrome and primary angiitis of the central nervous system. So I'll summarize by just comparing the three diseases because it's most important to differentiate them. So this is just the important differentiating features. So NMOSD and MS is much more common in women than men, and MOG has an equal propensity. And antecedent infection is very rare in MS or NMOSD, but is quite common in MOG. So if we have confusion in the three, this might help us arrive at a diagnosis. The clinical features are quite similar in all three, the three cardinal features, that is optic neuritis, myelitis, and brainstem syndromes, although the brainstem syndromes are a little less common in MOG. The cause most commonly in MS is relapsing remitting. In NMOSD, it's relapsing. whereas it's more monophasic in MOG antibody disease. Recovery is good in MS, not as good, but little worse, but better than NMOSD in MOG. But it's the recovery is very, very bad in NMOSD. So if you have a patient who has had some sort of demyelination and permanent deficits, might indicate that that person has NMOSD. The CSF in MS should show less than 50 cells, less than 100 proteins, whereas it's very variable in NMOSD and MOG. In fact, in NMOSD, we might see neutrophils and eosinophils as well. And now there is an increased interest in testing for interleukin-6 levels in NMOSD. Oligoclonal bands are found in 80% patients of MS, 20 to 30 in NMOSD, and just about 15% in MOG. And the prognosis, again, it's most patients with MS on good treatment would be ambulatory. In MOG antibody disease, the first episode is the critical one. If there are deficits, it's usually the first episode that causes these deficits. And NMOSD, like the MRI findings, which are extensively with extensive transverse myelitis, optic nerve, even the deficits are extensive and usually permanent. And this is just an illustration of the MRI findings. So a patient of optic neuritis, more than half the length, check if it's anterior posterior. If it's posterior with chiasm, NMOSD. If it's anterior, MOG. If it's patchy unilateral, probably MS. Spinal cord, again, if it's longitudinally extensive, is it cervical or is it lumbosacral? Cervical more commonly with NMOSD, lumbosacral more common with MOG antibody disease. Once and central, both of them. Again, patchy, more suggestive of MS. And the brain lesions, as we've described, MS has its own distinctive brain lesions. NMOSD has its characteristic ependymal pencil-shaped hyperintensities, area postrema lesions, internal capsule lesions, and similar findings can be found in MOG antibody as well. So just a few other examples of the various MRI findings. So we can see in the MOGAD part, the first one shows these cloud-like ADEM lesions, which are characteristic, and images L shows a extensive optic neuritis, which is more anterior. Thank you.
Thank you very much, Arjun. I think with Dr. Katrak's permission, shall we give them 1 minute to fill the forms, the Google forms before we take the questions?
Yeah. Please go ahead.
So please, all of you, if you can fill up the Google forms, which Azad has circulated on the group.
Very frankly, I don't have many comments to make. I think his presentation was very comprehensive.
Yeah.
Very nicely illustrative also.
Yes.
Only one point that I'd like to make. Some people may have a presentation like meningoencephalitis. Their case of MOGAD.
Okay.
Yeah. I think in some of the CMEs, one case was shown where it looked initially was thought to be a meningoencephalitis due to TB and treated as such. But then there was a lumbar spine lesion and then the MOG antibody positivity, and then they went to immunosuppressant. Yeah.
Fine.
So we can come back to the discussion. Sir, your comments, please. Anything else you want to say?
No, that's all. I just wanted to make that there is a patient from Hyderabad who actually presented with like a raised CSF pressure and abnormality, and actually had MOGAD and had the cortical and subcortical lesions, meningoencephalitis, and then enhancement of the meninges. Otherwise, I think he has covered extremely well. I should compliment him.
Thank you, sir.
Just one small comment, sir. I don't have a big experience with MOG, but there are also those subsets of inflammatory demyelinating disease who tend to have relapses even on rituximab. In fact, there is good data available which has compared various maintenance immunomodulatory drugs in these patients with MOG. And they feel that probably patients who are on oral steroids more than or equal to 10 milligram per day are probably less likely to have relapses than even those who are on rituximab. I've had two patients, one with myelitis, one with optic neuritis, MOG, who have relapsed with rituximab. So that's the time when we did a literature search, and probably this is one group where oral steroids are as good as any other immunomodulatory, but more than or equal to 10 milligram for a prolonged period of time.
I think the point that I asked Arjun to make is that we must consider plasma exchange in NMO spectrum disorders much more than in, say, MS or other conditions.
And probably early on.
Yeah, and early on, in order to get a good recovery, because these people are at danger for having residual deficits. So it's, I think, important to consider IVF. I have a greater preference, or I must say I had a greater preference for plasma exchange rather than IVIG, because maybe you call it my personal biases, because the raw material from IVIG comes from a pooled data, and I have a lurking suspicion that after 10 years, 20 years, I do not know how many cases of sporadic CJD we may get in patients who have received IVIG.
Oh, that's frightening.
Because it's a pool data.
Yeah.
I mean, they pool the proteins,
Correct, correct.
you know.
Sera.
You know. So you do not know what the status of these people are.
Correct.
So therefore, my preference for plasma exchange more than this. Very, you know.
Yeah.
But I would request you all to keep your eyes open, and next time you see a case of sporadic CJD, just ask for a history of any IVIG in the past.
Yes.
Complex.
No, IVIG.
The patient's own. You're putting in albumin. You know, but it is pooled sera. IVIG obtained from pooled sera. You see, it happened in the pituitary growth extract after so many years.
Correct.
So having a little bias for sporadic CJD, I am a little hesitant, you know.
Yeah.
Second thing, my bias is very bad, is that the most of the raw products come from China.
True, but Sarosh, not many patients with CJD have given the history of having IVIG before.
I don't know.
But we should ask the question. You are quite right.
Because we have been use the IVIG for the last 10 years. And CJD may come about after 25 years. So I really don't know, but this is just a thought. Perhaps you my personal bias or whatever you want to call it, but I'm a little in favor of plasma exchange rather than IVIG.
Sure, it works better actually.
Yes.
Angela Vincent always preferred plasma exchange.
Yes.
So are there any other comments, questions?
None. Thank you.
From anyone?
Overall, the presentations were very good.
Very good. Very good.
I might have a little advice for Abhijit and Vikas. Please do your presentations a little slowly don't try and complete your presentations in time by going at a very fast pace. This is
Okay, sir.
method of presentation. I'm not criticizing your slides itself, but you must reduce the number of slides, reduce the number of lines on slides, you know, and you must memorize your data and use your slides only as aid memoirs.
Thanks, Sarosh, but I'd like to compliment all of them. They've done an extremely good
Yes,
job.
yes, I
Yes.
think. I
Thank you
mean,
so
just as a teacher, I'm just trying to make them improve their presentation in future.
Sure.
Definitely, sir. I will work on it.
I'll leave now. May I? Thank you.
Yeah, so sir, thank you very much for joining today, sir.
And I hope
And
you
thanks
keep
everyone.
joining us.
I'm
Yes.
more educated now. Okay.
And thank you for sharing your experiences.
Thank you.
Yeah.
Thank
So I think we'll close at that.
I
Thank
think
you
you're
all.
phoning
Thank
me
you
up.
very much. The next continuum next
May I
continuum
just-
Azad will announce the
No,
topic
but I
and
think
this. Yeah.
we'll have a break in April because we have
Yes.
to plan out the next ones.
Yes.
Because the April will be on the 25th and the period is too short to organize everything.
Okay.
So I think we can begin from May onwards.
Okay. Yeah.
Okay. I've seen all the things.
Right, sir. Yes.
So we can plan the whole
I'll
thing.
phone you.
Yeah. Okay.
Yes, sir.
Thank you. Thank you,
Bye.
everyone.
Okay, sir.
Bye.
Bye. Thank you all.
Bye.
Thank you all.
Bye.
Thank
you.
you, Rajesh. Thanks,
Bye.
Azad.
Bye, sir. Thanks.
Yeah.
Thank you, sir. Thank you.
Take care all.
Thank you,
Bye.
sir.
Bye.
Thank you.
Bye.
Thank you.
Thank you.
Thank you, sir.